morning, everyone, and I'd like you to take your seats. Can you come in and take your seats so we can start on time? Hello, everyone. Let's get started because we have a very full agenda today. I'm Isabel Lusada, and on behalf of the Amyloidosis Research Consortium, I'd like to welcome everyone, and in particular the patients who have traveled here, because I know logistics are difficult. For a lot of patients, mobility is hard. I know there are quite a number of you who've been juggling dialysis and other similar things to get here, so we really appreciate the efforts that you've made to come. I'd also like to welcome members of the FDA. We have an excellent turnout from the agency, and I'm just so delighted that you can be here, and also that there are, I know there's some back at HQ who are watching on the webcast. We're at a pivotal moment in the history of amyloidosis, a crossroads. A number of companies are developing drugs or are interested in developing drugs for amyloidosis. We have 8 phase 3 clinical trials going on at the moment. Because of the challenges that rare diseases face and the complexity of this multi-system disease, and the challenges of clinical trials in this field, some of the companies are discouraged and leaving, and others are struggling with their trials. This is irrespective of the potency and efficacy of their therapy. With such a pressing and huge unmet need in our population, it's not something we can sit back and allow to happen. The ARC was founded out of this very real need and understanding the urgency to bring the stakeholders together to facilitate the design, accrual, and implementation of clinical trials that work for our patients, incentivize basic scientists and companies by providing services and building tools that support them, by bringing together physicians working in the field to share knowledge and expertise, and regulators to identify meaningful endpoints from what we see as valid biomarkers to meaningful quality of life endpoints for our patients. This meeting came about through a series of discussions earlier this year with FDA and expert physicians and companies working in the field. The recurring theme has been the need to create a draft guidance document to facilitate clinical trials and drug development. And key to the success is the need to have input from all sectors. We had a meeting in the middle of September for 2 days with experts from around the world and 14 companies that are developing therapies for amyloidosis, or considering it. And members of the FDA came. Because the ARC is a patient-driven foundation, we have a razor-sharp focus on delivering better outcomes for patients with amyloidosis. We also know it's critical that patients have input throughout the process. In rare diseases, patients are truly the experts. Fundamental to the success of any drug is understanding the patients they're being designed for. This is the next step in the process. To quote the FDA on patient-focused drug development meetings, the patient perspective is critical in helping FDA understand the context in which regulatory decisions are made for new drugs. PFDD meetings give FDA an important opportunity to hear directly from patients, patient advocates and caretakers about the symptoms that matter most to them, the impact the disease has on patients' daily lives and patients' experience with currently available treatments. This input can inform FDA's decisions and oversight both during drug development and during our review of a marketing application. Today, we're delighted to have an incredible turnout of patients. We have many more who will be listening in on the webcast throughout the day. So the meeting will loosely follow the structure of the FDA's very successful patient-focused drug development meetings. We'll start with a general overview of systemic amyloidosis and then focus in separate sessions on burden of disease, treatment, and clinical trials in AL and ATTR amyloidosis. We'll break around midday for lunch. And I know that for some of you patients, it's quite hard to sit for long periods of time, so please feel free to stand up and walk around in the back and stretch your legs at any point. So a few ground rules. To make the most of today and to maximize the input from each of you, please keep your comments on topic. Although we recognize the absolute imperative to get a timely diagnosis and the nightmare voyage for many patients to get one, This will never be a regulatory issue. So it's not something we want to focus on today, and there will be other opportunities with the consortium to look into that in more detail. It will be touched on early on in the day. There'll be we also have two excellent facilitators, Dr. Comenzo and Dr. Gertz. They are leading experts in amyloidosis, Rottweilers when it comes to timekeeping, incredibly compassionate and caring physicians who have dedicated their life to amyloidosis. The FDA are our guests, and I've assured them they don't need Kevlar jackets. So please be polite and respectful. They're here to listen and learn about amyloidosis. Likewise, as our guests, at any point we would welcome comments and feedback from the agency. So we have these interactive devices. There should be one per patient or their representative. And if you don't have one, there are some more available, I believe. And if you put your hands up, someone will bring one to you. And there's a number of you are here on behalf of someone who's passed away. You may use their experience to answer the questions. So to get a sense of who's here, we'll start with a few questions using the keypads. They are easy to use. We will bring up questions on the screen, and they have your choices. Just push the choice. So the first one, just to get a sense of where people are from and logistics. We have one more. Can we get one more keypad? Two more? Three? Okay, hold on a moment. We need lots of... Okay, we have a couple more. We have one more over here. Somebody's got one. Okay. Excellent. So if we start with the first question, where do you live? If everybody pushes their button, we can get... So 85% outside the DC area. I know we actually have people from all four corners of the country, so it's really amazing national representation. And the next question, please. What type of amyloidosis do you have? AL, ATTR, or other? I'm meant to be doing it too. %67% with AL, 24% with ATTR, and 10% other. And next question. Age. Looks like 31% between 51 and 60, and 37% 61 to 70. And quite a range, younger than 30. 3% younger than 30, which was interesting. And next slide. Easy question. Male or female? I'm doing the... %53 women, 47% male. And next slide, please. Which best describes your condition? Newly diagnosed, in remission, disease and progression, not sure. %5 are newly diagnosed, 48% in remission, 38% the disease is progressing, and 10% are not sure. All right, next slide, please. I think it's... All right, I would like to hand over to the next speaker, who is Mari. Dr. Gertz from the Mayo Clinic is going to speak about unmet need in amyloidosis.
Thank you, Isabel. If you could bring up my first slide, please. I've been asked to just give a brief overview regarding the commonalities of AL and ATTR amyloidosis. There's a lot in common, although they're fundamentally different diseases. They're both exceedingly rare. They both will disrupt kidney and heart and nerve function. They're both subtle and difficult to diagnose, resulting in very significant delays in diagnosis, which make it very, very difficult, thank you, to move forward with early intervention. And there's no single absolute diagnostic test to recognize this disease. There's no certain blood test or imaging. Even with biopsies, if not handled properly, the diagnosis will be overlooked, which remains an ongoing challenge for this disorder. This is a breakdown of Dr. Kyle's database on the monoclonal gammopathies over 53 years. And you can see, and this is pertinent only to the AL amyloidosis population, that in the differential diagnosis of monoclonal gammopathies, amyloidosis is a very important player. Now, there's referral bias here. 9% of monoclonal gammopathies are not amyloidosis. But it's important because many clinicians, medical students, and residents, when asked, what is your differential diagnosis of finding a monoclonal protein in the serum, they'll say MGUS, and then they'll say multiple myeloma, and then the room gets very, very quiet while we're waiting for a third possible explanation of the monoclonal protein, because it simply isn't on the radar screen of most of our practicing clinicians, residents, and medical students, because it is so infrequent. So if the diagnosis is not kept in mind, it will be overlooked. This is a breakdown just of 2014 of the amyloidosis that we're seeing, because there's been a seismic shift in what we're recognizing in terms of amyloidosis. This is particularly true of the wild-type TTR cardiac amyloidosis, formerly known as senile cardiac amyloidosis and senile systemic amyloidosis. The term is no longer used because of the confusion that results when the term senile is used, meaning aged, which is inaccurate because wild-type TTR occurs in patients as young as 50 years of age, and of course the confusion between senile and a dementia illness, which of course is not the case. So we've seen, if you look back to 1960, about 2 to 3% of all amyloid that we see is this senile or wild-type TTR. But in 2014, that went up to over 20%, and that's being driven because now there are clinical trials available. And with the presence of a clinical trial, then the motivation to seek out an accurate diagnosis is clearly present. And so there's momentum that's simply driven by the fact that there is something that I can participate in. Placebo-controlled or not, there are now opportunities for me that will drive me to go forward with a diagnosis. Even so, AL amyloidosis remains the big player, at least in the Mayo Clinic referral practice, with over half of patients with systemic immunoglobulin light chain amyloidosis. And for those of you with ATTR, AL means amyloidosis that's derived from an immunoglobulin light chain produced in the bone marrow. And for those of you with AL, ATTR is amyloid that is due to transthyretin produced in the liver. But still, we still see now a significant number of hereditary amyloidosis, but even that is moving up. Even that 20 is going to be probably 50 in 2015, again being driven by the availability of 3 clinical trials at Mayo for the treatment of ATTR, which is pushing people to seek out centers where they can access therapy. Classification of the amyloid is paramount, and it's been approximately 6 years now since the widespread introduction of mass spectroscopic analysis to determine what is the subunit protein of this amyloid fibril, to determine AL from ATTR and from some of the other recently recognized ALEC2 and some of the other less common forms of amyloidosis. Back in my day, everyone who was diagnosed with amyloidosis was automatically assumed to have systemic AL. That is blatantly incorrect, and I'm sure over the years I've inappropriately and incorrectly treated patients with chemotherapy that they did not need because of our inability to distinguish the subunit protein. And although AL remains our most common, from the mass spectroscopic evaluation of 5,000 biopsies, 28% of patients with amyloidosis did not have amyloid, light chain amyloid, for which chemotherapy would have been contraindicated. The problem with this disease is patients generally present to their internist because they have swollen feet or numb feet, or they're short of breath, or they're tired, or they can't climb a flight of stairs. And these are extremely common complaints in a general practice. And if you look at the average internist in the United States, it is the expectation that in their 30-year career, they will never see a patient with systemic amyloidosis. A hematologist or an oncologist would expect to see one patient with light chain amyloidosis every 4 years, roughly, if they see 1 or 2 new myelomas a year, which is a ratio of 5 to 1. And if you look at the percent of patients, 12% have neuropathy, 48% have kidney, and regarding cardiac, 40% have cardiac. So there's not one physician group that we can easily target to educate and say, you need to watch out. You've got to grab everybody. Most of these patients have combined problems of heart and nerve, but it's very difficult to get cardiologists to focus on carpal tunnel syndrome and peripheral neuropathy. Likewise, it's very difficult to get neurologists to focus on shortness of breath, difficulty climbing stairs, progressive fatigue, because it's just not in their comfort zone. And so it becomes very complex in trying to get to the root cause. And because of the large number of physicians that can be involved, simple educational techniques have been very, very difficult to bring home early diagnosis of this disease. AL and mutant TTR neuropathy are clinically indistinguishable, even though the site of production is the bone marrow in AL and the liver in ATTR. Once neuropathy or cardiomyopathy develops, it is subtle to make the distinction. Expert echocardiographers with imaging can make the distinction, but by and large, in the community, you can't tell the two apart readily. One of the differences is that for some reason you can get much greater infiltration of the heart with wild type and mutant TTR, wall thicknesses of 18 to 20 on the echocardiographic septum, numbers that are rarely obtained in patients with AL because they develop serious problems long before then. And usually this can only be recognized at specialized centers. If you look at the clinical trial endpoints for organ response in AL and ATTR trials, those endpoints are virtually identical in terms of looking at changes in cardiac biomarkers or looking at changes in the neuro impairment score or looking at the 6-minute walk for that matter. The only thing is that in AL amyloidosis, there's also a hematologic response endpoint that does not exist in ATTR amyloidosis. This slide basically shows how little progress we've made in AL amyloidosis. This is data from Dr. Kumar at Mayo Clinic looking at what has happened in the diagnosis and survival of patients with amyloidosis over a period that's now approaching 40 years. And the real shame of this is that you can see that within the first 14 months, nearly 40% of patients succumb to this disease, and that despite the introduction of organ transplant, marrow transplant, chemotherapeutic agents, we still are not making progress in patients who present with advanced cardiac amyloidosis. And this high early death rate makes it very difficult in the context of clinical trials to demonstrate differences between regimens to help our patients select the optimal regimen for them. There are a number of challenges to improving the outcomes for our patients. Failure to recognize is a big problem. If there's only 3,300 AL patients, and we have no idea how many TTR patients there are in the United States. We don't understand the penetrance of those that have inherited. We don't really understand the full prevalence of wild-type TTR, and the lack of diagnostic examination. It's not like lung cancer where there's a spot on a chest x-ray and you go, oh, that spot is abnormal. We just lack something that will tell our clinicians, oh, think about amyloidosis. And again, biopsies can be obtained showing, for the physicians in the audience, amorphous, eosinophilic, hyaline material that basically doesn't look like anything and without Congo red staining will be missed. In our institution, we have a problem with intestinal biopsies, which are a very common source of finding amyloid deposits. And our pathologists are uniquely resistant to staining bowel biopsies with Congo red. And it's very common in my practice to have to call the pathologist and say, you didn't do Congo red stains for amyloid on the bowel biopsy, and they'll say, well, there was no clinical evidence or any clinical suspicion of amyloid. And I said, well, there was no clinical suspicion of Whipple's disease, but you did those stains, and amyloid is easily as common as that, so I don't understand the artificial distinction. The other thing that Dr. Merlini has brought forward is that in the MGUS population, clinicians monitor for changes in the protein looking for the development of multiple myeloma. But the development of AL amyloidosis in an MGUS patient commonly will occur with no change in the level of the protein, but the development of amyloid. And so the only way to recognize is to monitor these patients for the development of proteinuria or cardiomyopathy by serialized measurement of cardiac biomarkers. And this is a message that we're trying to bring to community physicians. It's 5 syndromes that we try to focus on in terms of the diagnosis of amyloidosis. And those are when there's heavy proteinuria, when there's heart failure with preserved ejection fraction, which is actually the most difficult, peripheral neuropathy or chronic inflammatory demyelinating polyneuropathy, the presence of an enlarged liver without imaging abnormalities, or those hematologists, oncologists confronted with patients who have atypical multiple myeloma. But the problem is even those symptoms are relatively vague: fatigue, swelling, shortness of breath, weight loss, and I can think of scores of more common problems that will lead to those symptoms. And the signs, such as periorbital purpura or enlarged tongue, are highly specific, but no more than 15% of patients have them. So if we're going to wait for that to occur, we'll miss 85% of the patients with the syndrome. This is ATTR, just a demonstration, first of all, that the distribution of mutations in the United States does not resemble the distribution in Europe. In Europe, by far, the most common mutation is V30M. That is not the case in the United States, where every center I've spoken to, T60A is the most common. You can see that the distribution, this is at Mayo, peaks in the 7th decade, between 60 and 65, but patients as young as under 30 and patients over the age of 75 can be afflicted with this devastating diagnosis. So I'm going to summarize, and then we'll bring on some important patient commentaries. Much has been invested in the development of new agents for multiple myeloma. Extensive utilization of stem cell transplantation has been used. 3 new drugs will be approved in the next 12 months. 4 drugs have been approved in the last 5 years. Yet amyloidosis, which has a survival approximately 40% that of multiple myeloma, is still not recognized, somewhat ignored by both the patient and medical community. And we've seen amazing gains in survival in multiple myeloma. Since I've been practicing, it's tripled in terms of the median survival. These gains have not been translated to the amyloid population. So simply saying we're making such great progress in myeloma, that will have a trickle-down effect for the amyloid population is simply not the case, and unique interventions are required for the amyloid population. And of course, the causes of this are not only just a lack of available therapies that are specific to this population, but failure to recognize until patients develop advanced organ failure and are pre-terminal. Moreover, the amyloid population is uniquely fragile, and it's been shown again and again that the typical strategies for myeloma in terms of transplant and dosing and the impact of certain classes of drugs have a much more profound effect on the amyloid population, so they need specific trials to understand the unique toxicities that they face. And I think with that, I will cede the podium. Isabel, then, will you be introducing our patients? Thank you.
So we're going to start off hearing from 3 people who've had very different experiences with amyloidosis, AL and TTR. And first of all, I would like to introduce Catherine Timpf.
Hello. My name is Catherine Timpf. I'm not a patient myself, but I lost my mom to cardiac amyloidosis a year ago as of November 5th. She was 57 years old. She was a social worker, a wonderful person, helped a lot of kids. I know I'm not the only person that misses her every day. And I've heard of a lot of stories that are similar to hers. It all started in March of last year. She just had some shortness of breath. Went to the internist, and they said, you have asthma. So she was diagnosed with asthma. She was put on an inhaler, but then things were not getting better. In June, they discovered that she had some fluid in her lungs, and her liver was swollen, and we were all concerned that she had cancer. She'd also been a cancer survivor from when I was in college, but that was totally unrelated. She didn't have cancer, and we found out that she didn't have cancer in July. We were elated, and I remember getting a message from her saying it was a miracle. We were so excited because I guess they just figured if there's no cancer, they didn't really think about anything else, even though they had found signs of an invasive disease. So there was something that looked like attacking the organs. But still, because of the shortness of breath, the swelling of the ankles, and all of those things are common in a lot of conditions, they just assumed it was AFib, put her on heart medication, and it helped the symptoms a little bit until about August and September. She got so bad she couldn't walk up the stairs. We didn't know what was going on. September of last year was the first time we ever heard a phrase cardiac amyloidosis. She was finally diagnosed in October, and we went to Brigham and Women's in Boston for treatment. I live in New York, so I was living like half New York and half in the hospital. And they did have treatments to help, and they did have chemo, but it was already too late. She was already 2 weeks, so she passed away about only 3 weeks after being diagnosed. So it was a nightmare, and it still is kind of a nightmare. And something that I learned from this, and I'm gonna give the next person a turn, is it's a lot of times the diseases that really need awareness the most, it's kind of hard to create those kinds of efforts because not enough people seem to know about it to even start something like that. So I'm really glad to see everybody here today, and thank you all for listening. Thanks.
And our next speaker is Sandra, who is going to talk about her experience with AL amyloidosis.
I'm going to read because I'm nervous. First off, I'd like to thank you so much to the FDA for being here. It means a lot to the patients. I, like so many primary amyloidosis patients, do not fit the amyloidosis patient stereotype. I don't have a swollen tongue, I don't have purple around my eyes, and I'm not an older man. I was diagnosed when I was 42 years old, 7 years ago on Halloween, and that night I went trick-or-treating with my kids who were 6 and 8 years old, and my doctor told me I had 2 years to live. I'd like to describe to you the 3 most significant impacts of amyloidosis on my life. First off, physically, before being diagnosed, I used to love running. I ran long distances, including running marathons and running almost daily. Sadly, I cannot run anymore, and I can't play any longer as my heart cannot handle it. I can't go on strenuous family hikes or a roughhouse with my kids like I used to. The treatment side effects are profound as well. As part of my treatment, I'm on weekly steroids, so no sleep for a couple of nights a week. Lots of you guys know what I'm talking about. Constant diarrhea, which is pretty tricky as I'm a full-time 4th grade teacher, so quick trips to the bathroom. And the drug effects, the fatigue, and the chemo brain are frequently debilitating. The second greatest impact is the constant emotional stress. Managing amyloidosis takes a significant amount of time in my daily life. I'm plagued by constant questions and uncertainty that I just simply never had before. I live by the numbers. What are my free light chain values this month? Did they go up? Is the upward trend significant enough to change treatment? What are my options? Are those options approved for amyloidosis or only myeloma? Why do I have to worry about drug availability, even though treatments for myeloma and amyloidosis target the destruction of the same plasma cell? Why am I not eligible for so many trials that have the capability of helping me? My kids and husband have to live with the knowledge that I have a terminal disease. Their mom is going to die, and they know this. When I had a stem cell transplant, my family saw me being incredibly weak, a huge departure from their previous image of me. When the transplant wasn't effective, they had to deal with the fact that I had to immediately return to weekly chemo. To my kids, it simply just seemed unfair, and that's a huge burden to carry, and they carry it every day. Lastly, believe it or not, one of the hardest aspects of this disease, and the patients will know this one, is the constant uncertainty of treatment-related finances and insurance issues. This is so emotionally taxing, it is like having a second disease. The insurance companies have no awareness of amyloidosis, make decisions that are medically unsound for us, and the bureaucracy and inhumanity are staggering. I have finally passed this burden completely onto my patient husband. He is at his wit's end. We go through multiple appeals so that I can be treated at a center of excellence and not at the HMO who has never treated an amyloid patient. The drugs I need are not labeled for amyloidosis, and my doctor has to say that I have myeloma for me to get the medicine. Because of the lack of FDA-approved drugs, I worry if my treatment will be covered and if the copays will be affordable on my teacher's salary. We have to fight and appeal every single issue. What I really need and want is to stop the production and deposition of the proteins and not feel like I'm running through the list of drugs that can keep me alive.
Thank you. Thank you, Sandra. That was amazing. Dylan, can I invite you up to talk?
Hello, my name is Dylan and I have TTR amyloidosis. I was 27 when I was first diagnosed, but the disease has been with me for most of my life. When I was around 11, my mom received a positive diagnosis after experiencing some neuropathy in her legs. She had a liver transplant in Boston, but continued to be very sick for years after. As teenagers, we spent a lot of time in the hospital, as she would have her regular weekly appointments, or would sometimes be admitted for up to a month. I recall the physical and emotional transformation that came over her. All the weight she lost because she couldn't keep her food in her system, the severe and uncontrollable diarrhea and vomiting, the adult diapers she had to wear, her puffy face and swollen feet. She was disappearing right before us, becoming more weak and hopeless by the day. I would ask my dad quite often if she was going to die, and sometimes I wanted her to. It was that hard. I have vivid memories of her last days, laying with her in her bed, us both facing the mirror across the room and her telling me how handsome I was becoming. Making me my favorite French toast even though she had to do it from her wheelchair. I just said that. And how she watched my sister's prom grand march, not with the other parents at the event, but through a videotape recording from her bed. She never saw either of us graduate high school or me ever have my first girlfriend. She missed so much and tried to stay with us as long as she could, but she died on May 26, 1997 at the age of 45. The emotional effects and the anxieties that came from being surrounded by this disease as a kid has lived with me up until now. Today I'm facing the physical side of amyloidosis and learning to cope and manage some of the symptoms that I've developed. The first major change that occurred a couple years ago was my sudden erectile dysfunction. Soon after, I experienced my first episode of nocturnal incontinence, which was absolutely horrifying. It marked the very moment when I realized that I was in my mom's shoes. I had already been experiencing frequent bouts of diarrhea, but losing control of it at night was so traumatic, and it continues to be so. I began wearing extra shorts and underwear while I slept, packing towels in my travel bag when visiting friends so I could cover the bed sheets, and ultimately deciding to wear incontinence briefs at night, which was very hard for me. The combination of all the diarrhea and decreased appetite has caused me to lose a lot of weight in the last year, and it hits home when people mention it. I dropped down a couple jean sizes, and I seem to swim in my older dress shirts. And I noticed that this morning, actually, when I put this one on. I experienced lightheadedness upon standing up, even after climbing one flight of stairs, and I feel more tired and fatigued than I used to. A couple months ago, I passed out from getting out of bed too fast, and luckily my girlfriend was there to catch me. So much has happened to me in the last couple years, but I know it's just the beginning. I'm very scared of things getting even worse and how it will affect my quality of life. I worry about my sister, who has been diagnosed and has a beautiful 3-year-old daughter who has the chance, too, of living with this disease. Or, like us as kids, having her mother being sick. And I, of course, worry about having my own kids. My girlfriend and I talk about it, but the uncertainty of my health situation and the chance of passing it on gives us hesitation, even though we'd love to. I have seen what this disease can do, and I know what is coming for me, for my sister, and for so many others. And I look forward to when it can be stopped. Thanks.
Thank you. Those were actually quite moving. Our next speaker began his career in the laboratory of the world-famous Jan Waldenstrom. He's currently the director and probably the best-known amyloidologist in Europe, maybe globally, directing the Amyloidosis Center in Pavia, Italy, Professor Giampaolo Merlini.
Well, it is difficult to talk after this free presentation from the patients. And if ever they will ever motivate us to do better than we do. So I'm immensely grateful to the organizer, the Amyloidosis Research Consortium, Isabel Luzada, and the other friends from the Amyloidosis Foundation for inviting me to this very timely meeting to discuss about is indeed a pivotal time for this disease because we are experiencing an unprecedented progresses both in understanding the disease and in developing new drugs. And I will focus on AL amyloidosis because, as you have heard, is the most common one and is where we have the largest experience also in the use of biomarkers. So through the years, we have understood that this disease is indeed caused by a small but very dangerous clone in the bone marrow. And it took time for the hematologists to recognize that this clone needs to be treated aggressively. That is producing a misfolded protein that through the interaction with the cells and microenvironment, they aggregate into oligomers. And these oligomers might just go on a pathway to form amyloid fibrils that they deposit in the organs, causing damages. But we do believe that the misfolded protein and the oligomers are directly toxic for the heart. Both the deposits and the precursors are working together to make this damage because the fibers can have a surface that is catalytically favoring this transformation of this protein into a more toxic species and forming oligomers. And they can also dissociate in monomers and oligomers that are also toxic. So it's very important to get rid as soon as possible of the precursors of the protein. We heard about the free light chains, but it might be also useful to get rid of the amyloid deposits. This process targets all vital organs, and the heart and kidney are invariably involved in almost all of our patients with amyloidosis, but practically all organs can be involved except the brain. The heart is the driver of this disease. This is our experience in almost 1,000 patients now, and if you have only liver involvement, at 10 years you have not reached the median survival. But if you have heart involvement, and as we have painfully heard a few minutes ago, particularly if it's diagnosed late, even now, at 6 months, we still lose 30% of our patients because of late diagnosis. So this slide tells you a lot about this disease. We have made progresses, but we need to be much better in early diagnosis, and we need more drugs to help also these patients with advanced cardiac involvement. So the early diagnosis is the key for this disease, but we also need novel therapies. So the point of my presentation is how can biomarkers help us in this? And the possible role of biomarkers came from the observation of a single patient that we made several years ago. She was a lady who presented with severe heart involvement, and to our surprise, striking surprise, there was a very close parallelism between the concentration of the protein, the amyloid protein, and this NT-proBNP, the amino terminal part of natriuretic peptide type B, is a hormone produced by the heart. So, and what really struck us was there was such a close correlation between the clinical condition of the patient and this biomarker. while the total amount of amyloid in the heart remained practically the same by echocardiography. So this gave us the idea that the light chains can be directly cardiotoxic to the heart and also provide us with a formidable biomarker that might be useful to follow up these patients. This was a single patient. We went on and we published a few years later that indeed it was the case. The free light chains and the NT-proBNP moved together, and they were associated with a significant improvement in survival, and that is the most important part. So this gave us the idea that we can really change the biology of this disease if we can act rapidly in these conditions. And we went on to understand why this was the case. And investigators at Boston University, together with investigators at Harvard, made seminal discoveries that we also implemented more recently. They discovered that the light chains can be directly toxic to the cardiomyocyte through the activation of this pathway, the p38 MAP kinase pathway, producing oxidative stress into cardiomyocyte that results in cellular dysfunction. This is why the heart starts immediately to work less, and cell death. So we lose cardiomyocyte as the disease progresses. Very importantly, this same pathway is involved in the control of the production of this biomarker of NT-proBNP. So this provides us a formidable link, pathogenic link between the mechanism of the disease and this biomarker. And in fact, if we can block this pathway using these inhibitors that are used in cardiology in clinical trials now, losmapimod, we can both suppress the cardiotoxic effect of the light chain and also the synthesis of NT-proBNP. Such a powerful link provides us a tool that is now essential both for early diagnosis, for risk stratification, and to assess the response to therapy, most importantly. So the idea of early diagnosis has been exploited because this biomarker has 100% sensitivity to detect the cardiac involvement. And as you can see, the dynamic range is huge. So we see thousands of increases, not 1 or 2 times, thousands. So it's such a powerful biomarker that we propose, as Maury Gertz suggested, we can use this biomarker to follow up patients at high risk, such as our patient with MGUS with abnormal kappa lambda ratio. So if we implement this using the clinical practice, I'm sure we will detect patients with early heart involvement, and we can start treating them in time. So the whole idea is that we have to move from where we are here, where we made the late diagnosis according to the symptoms, and most of these patients are doomed to advanced heart failure, but we cannot recover at present time. And we have to move backwards and forward at the same time, just to identify this patient early in time using biomarkers when it's still possible to recover the cardiac function. Because we know that it's possible to recover the cardiac function if we act in time, when the NT-proBNP is less than 8,500. The same biomarker proved extremely important to assess the risk for this patient. And nowadays, we treat this patient according to this biomarker. So the treatment strategy depends on 2 biomarkers, a biomarker of organ dysfunction, that is NT-proBNP, and the biomarker of organ damage, that is troponin. So Angela Dispensieri and other investigators at Mayo Clinic found that if you have significant heart involvement, your prognosis is worse. And they went on and they documented that if you have a lot of these cardiotoxic light chains, more than 180 milligram per liter, and you have a cardiac involvement, your prognosis is very severe. So this has led to the identification of 2 powerful biomarkers that are now driving our clinical practice. One is free light chains, and the other is the severity of heart involvement using NT-proBNP. So we use the same tool to assess the response to therapy. The goal of therapy is to recover organ dysfunction and possibly to prevent organ dysfunction. So the organ response is really the ultimate goal of treatment. So we had to translate the clonal response into organ response, cardiac response, in order to improve the survival. So it's an obligatory link, this one. We have to improve cardiac function. It's not enough to have a hematological response, as has been shown by colleagues at Mayo Clinic. If you have only hematological response, you just normalize the free light chain ratio, but you don't have cardiac response, your survival is not as good as you achieve a cardiac response. So indeed, cardiac response should be our aim of treatment. And we have made a collaborative effort all over the world to define these criteria for hematological response. As you can see, we have shown that if we reduce or we eliminate the light chain, the biology of the disease changes completely. So we can really change the natural history of the disease if we intervene in time and we eliminate the cause of the disease, that is the amyloid protein. And furthermore, we have validated in the same study, international effort, that if we reduce the concentration of NT-proBNP by 30%, or at least 300 nanogram per liter, again, the biology of this disease changed completely. So we can change the natural history of the disease nowadays. And these powerful biomarkers can tell us if we achieve this goal or not. And if you have stability, you have some benefit, of course, but if you have progression, then this indicates you that you have to change therapy quickly and in time in order not to waste time and life for the patient. So using these criteria that are outlined here, we have validated these retrospectively in several patient populations. And again, it's always the same. If you achieve a response in NT-proBNP, you have a significant improvement in survival compared to patients with stable or progressing disease. And this is true irrespective of the type of treatment that you use. So all types of chemotherapy that we have used are producing the same results. And so overall, we have 5 studies, retrospective studies, performed in almost 1,000 patients that are listed in this crowded slide. But the point is that all these studies invariably demonstrate that responder and non-responder, according to the cardiac biomarkers, have a dramatic difference in survival. These were all retrospective. So we were lacking prospective studies because we don't have prospective studies in amyloidosis so far, because it's very difficult. It's a rare disease, we have few patients, and we need to join forces. And in Europe, we have been able finally to run these prospective studies, comparing classical treatment, melphalan dexamethasone, with the new addition of bortezomib, melphalan dexamethasone, thanks to the support of Millennium, that was also very supportive in this effort. And I'm very pleased to show you for the first time, because these are very new data, that even in prospective studies, NT-proBNP has proven to be a powerful marker of survival. We don't have yet data on survival because the study is rather fresh. The median survival is only 22 months, but it's already clear very significantly that indeed NT-proBNP, also in prospective studies, has shown to be an excellent marker that we can use as endpoint in clinical studies. For renal response, renal can take years to respond, and for this reason we needed to have new criteria for response, and together with our friends in Heidelberg, we have validated that if we achieve a renal response at 6 months, so time is always important here, we can significantly delay the progression toward dialysis compared to patients who do not achieve renal responses. So overall, we have proposed, thanks to initiative of Ray Comenso, as a community of amyloid community, that indeed For phase 3 studies, hematological, cardiac, and renal response using these validated criteria are more appropriate primary endpoints than survival. And our hope is that the use of this biomarker will accelerate the development of new treatment. As you have heard from our patient, we do still new treatments. And this may accelerate the trial as we have simulated in this study. So we will perform a cardiac study targeting patients with cardiac amyloidosis using as an endpoint survival. According to the statistical evaluation, we will need 360 patients. That is a huge amount of patients for a rare disease like this one, and more than 6 years to complete the trial. If we use as an endpoint NT-proBNP response, we will need 220 patients. That is a significant reduction in patient number, but we can have an answer for our patient in approximately 3 years. So we cut down by half the time that is needed to perform this trial. So it is a new era. You will hear from Angela Dispensieri that we have many new drugs now that are available for this disease, both targeting the plasma cells and targeting also the new knowledge provided us with new drugs, such as doxycycline, epigallocatechin gallate. There will be a very important oral presentation attached soon on this drug. But we can also now remove the amyloid deposit using new drugs. So these are unprecedented opportunities for our patients. At our center now we have 10 trials running with new drugs. That was unthinkable for this rare disease. But we need to move quickly. We need to develop these drugs to know if these drugs are effective in short time. And biomarkers provide us a powerful tool to achieve this goal that we owe to all our patients. So the final goal is to accelerate the recovery of cardiac function. And this might be done by early diagnosis, of course, but with new and more effective drugs. So to conclude, is indeed a new era for systemic amyloidosis, finally. I mean, during the last years, we have seen unprecedented development in the knowledge and in new drugs. Companies are very much involved. I'm pleased to see many companies present here today for this rare disease. We have validated NT-proBNP both analytically and clinically. We do believe that these biomarkers, together with phe light chains, can serve as a precious tool to develop new drugs. And since the normal endpoints, such as survival, will take years, we really need to implement these biomarkers in clinical practice and in trials development in order to develop this drug quickly. So for the sake of our patient, we do really believe that time is now to act. And thank you for your attention.
As a patient representative who so desperately knows and sees the need for new treatments, I've really been heartened over the past year at the engagement of the FDA, and I've spent many, many, many hours speaking to them. So it is really with absolute delight and pleasure that I introduce the Director for the Center of Drug Evaluations. She's an inspirational advocate for the needs to elevate the patient voice during drug development. Dr. Woodcock.
Thanks very much, Isabel, and good morning, everyone. I'm really happy to be here. I thank the organizers for inviting me. As we've just heard, and most of you know, amyloidosis is a rare and very serious disease that lacks FDA-approved acceptable therapies. And the lack of FDA approval, of course, leads to, in this country at least, leads to some of the problems you've heard about as far as reimbursement and getting treatment. Like many rare diseases, too, amyloidosis is actually a collection of even rarer serious diseases that have been lumped together and are now being dissected into subtypes. But this complicates the search for new treatments because each of these subtypes may be more uncommon. But the good news, as you've just heard, is that biomedical science is finding out the underlying molecular causes of amyloidosis. And this opens up new targets, we call them, for drugs, so that we can intervene with drugs in a very targeted manner now that we understand better what's going on, what's causing the symptoms and the pathology to happen. Now, FDA is really committed to helping people with rare, serious diseases. We know these folks have been neglected over the years in drug development, partly because the disease wasn't very well understood, and partly because drug companies, drug developers, when not much was known, would choose other pathways, more common diseases, where they knew more about it, and there was a market known, and a pathway to getting their drugs developed. What's needed in rare diseases are, number one, incentives to get people to develop drugs, and then a clear pathway that they can follow. What do they need to show? What do they need to do to get a drug on the market, for example, in the US for that particular disease? Now, the Orphan Drug Act in the United States, of course, provides great programs for products that are designated as for orphan diseases. They get exclusivity if they get on the market. Exclusivity is awarded, and that's a very good incentive. And there also is a grant program before market to help, because often these are small companies developing drugs for these rare conditions. But obviously, much more is needed. And what the FDA has been trying to do is provide that clarity, of that development clarity, that pathway. So if companies have a drug that looks like it could work in one of these rare diseases, they know what they have to do to get the drug on the market. I can tell you this is about the most important thing. And you just heard from Dr. Merlini. Having biomarkers that can guide development is extraordinarily important, because a company can try a drug just in a few people and they can see if there's an effect on that biomarker. And that's just tremendously helpful in knowing that you may have an effective therapy. And that will attract developers into the disease because they know they can find out pretty soon whether or not the drug has a chance of working. So how do we help with all of this, and how do we help patients? Well, the Center for Drugs, that I head, really is doing a lot of things. We're very interested in interacting with patients and the advocacy community around a lot of different initiatives. First of all, you heard about the patient-focused drug development meetings. This is something we negotiated with the industry during our last user fee negotiations, which were 3 years ago. And we said we'd have 20 of these meetings. This was an experiment, really, to see, could we hear the voice of the patient? Would this work? Could we understand diseases better? We've had quite a few of these meetings, and they have been incredibly insightful. We've learned so much from these meetings. The goal is not for FDA, though, to hold all these meetings. The goal is to help train and teach and work with advocacy and patient groups so that they can gather this information. And so, because there are 7,000 rare diseases, and probably if you divide them up into subgroups, there are actually many more. And so the FDA would not be able to do that, but we can benefit from the information that is gathered. What we have learned from these meetings is that often we're not studying in clinical trials what the patients care most about. And it's a medical model where we study things that we think will translate into what the patients care about. But we can't really tell the patients directly often at the end of a development program what this will do for you. If you take the risk of taking this medicine, what kind of things will it do for you? So we can do much better than that. And that's where we want to work with patient groups to develop quality of life and patient-reported outcome measures. So even if we're not curing the disease, we can actually find out how it impacts the symptoms patients care most about. So that's a very important thing. We also are working with patient groups to understand what's called the natural history. And what do I mean by that? Well, I mean, how does the disease unfold over time? And usually when a rare disease is first looked at carefully, people, they turn to the experts and they say, in my experience, it unfolds like this. Okay? But what we just heard in the last several presentations is the disease unfolds very differently depending on what its underlying cause is, amyloidosis that is, and also where the patient starts, how severe their disease is, and other factors. So it's going to be very important to understand the natural history of all the subtypes, and also what happens when people are treated, because we want to continue to get better all the time and do better and better against this disease. And patients can help with that. Biomarkers also can help, and we are really encouraging patient groups to work on biomarker studies, but obviously this disease, it appears that diagnosis is still a real problem. Diagnosis is very late. I remember when I was a young internist, one of my first patients came in with carpal tunnel syndrome, and I treated him for that, and then maybe a year later, he developed cardiac problems. He had systemic amyloidosis. At that time, it wasn't known what type of amyloidosis that might have been. So, and that's still happening, it sounds like. People are presenting with symptoms, but their underlying cause is still unrecognized. Once you can get a biomarker panel and people can order a blood test, then all of a sudden it becomes a lot easier to identify people earlier, okay? You don't have to go around biopsying different parts of their body and so forth. So this could be extremely helpful in moving that diagnosis back earlier in the course of the disease. We also want to hear from patients about the trade-offs. We know that many of the treatments now that are being used in people have serious toxicities. You've heard about some of them this morning. And the question is, how much is it worth trading off in the disease? You know, what matters to the patients? What do you want to have helped, and how, you know, what do you think about these different toxicities? It's hard for FDA to make that kind of benefit-risk assessment alone without understanding. And of course, in a disease, they're going to be risk-taking people, just like every other part of life, and there'll be people who are very conservative. And so we want to provide the information that people can use to make decisions themselves, especially if the treatments are going to be risky or toxic. Now, you've heard a little bit about guidance development. A guidance is a document that FDA puts out, and that provides that clear pathway. We say to the drug developers, you can do what you want, but we suggest you do this, 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 or this. Maybe give them choices. We use these endpoints, study for this long, and that helps, again, attract people in, have some certainty. In some cases, patient groups, and along with expert clinicians, have gotten together and actually written draft guidances to send to the FDA, or pieces of guidance, or have just submitted their opinions on what should an endpoint be, or the kind of study. And this can be very helpful. And also, I think it helps the community clarify their own thoughts about where the disease is and the treatments at the current time. Up till this point, often for rare diseases as well as even common diseases, there's been a lot of fragmentation around the world, all right? And even in the United States, different centers would do things differently, and there'd be, in my experience, it happens this way and so forth. We need to get to a more uniform consensus understanding where we can use the data from all the patients, because for a rare disease or a super rare disease, there just aren't enough people to fragment and do things differently. So we would welcome efforts at guidance development. And finally, we heard about biomarkers. Well, how do you do this? Well, FDA has put together something they call a qualification process, and that's a new word. Qualification, we made it up more or less, not the word, but the use of it. And that means, how do you decide that something is good enough for maybe not prime time, but for regulatory use? Okay, how do you decide a biomarker or a drug development tool, a trial, whatever, is good enough to make decisions that would maybe lead to drug approval or not? So that kind of, you have to be some substance behind that, right? And so we have this process where you can submit data on a biomarker or other drug development tool and go into a back and forth with the agency. And if the agency finds it reasonable, we will then publish something and say, a guidance, actually we'll publish a guidance that'll say we found this tool useful. For example, we could say, potentially, we think that NT-proBNP is useful for stratification. Okay, that's not very hard, right? That's not a very hard one. Or useful for putting people into trials for diagnosis or something like that. But the consortium has submitted a proposal to us for NT-proBNP to use it as a surrogate endpoint or part of a surrogate endpoint. What is that? Well, that's what Dr. Merlini was talking about. That is a collection of factors that we declare that a therapy worked. And this is how you could compare a new therapy to older therapies, a traditional way in a disease that has fatal outcomes would be to do survival trials, but sometimes you can compare the biomarkers, as Dr. Merlini showed much earlier. And a good example of this is HIV. We use a blood test. And I will tell you that blood test, which is viral load, is used for early diagnosis, it's used for monitoring therapy, and it's used as a surrogate endpoint in clinical trials for HIV. And all of that means that the knowledge can turn very quickly, and we can crank out new therapies, and we can try to stay ahead of HIV because it's an infectious disease and it keeps mutating the virus and you have to stay ahead of it. So there's a need. You can't just do long trials and wait a long time when you're dealing with an infectious disease. So the viral load measurement, which was very controversial when it was first adopted, is now basically the standard of care and has helped us bring that epidemic under some control. So the question is, could, at least in the some forms AL amyloidosis, could this be part of a criterion for hematologic response? So what we do is we go through a process to evaluate this. The FDA has a mechanism to get drugs on the market early for serious and life-threatening disease. That's called accelerated approval, okay? And accelerated approval means we approve a drug based on a biomarker that we don't necessarily 100% know is going to predict good outcomes. A biomarker that we approve drugs on all the time, it's not accelerated approval, is, for example, blood pressure. Okay, everybody knows, you shouldn't have a high blood pressure, you're gonna have more strokes and so forth. So we just, if drugs lower the blood pressure, and then we approve the drugs based on the blood pressure trials, okay? But sometimes we don't know what that biomarker is going to predict, but if it's a very serious disease and it doesn't have good therapy, we're willing to take a chance on that. So that's what's been proposed by the consortium, and we will definitely take a look at this. We have a process, and I'd like to use this as a process for us to really evaluate our criteria for accepting surrogate endpoints for accelerated approval. So I thank the consortium, and they need to send in a whole bunch of information and data. And if you worry about, well, this is global disease and so forth, we have worked with the regulators in Europe and who now have a qualification process too, and we've worked with the Japanese regulators and so forth, and I think there's a good worldwide awareness of this qualification process and program and what it means. So I certainly commend the consortium. I think this is the only real way to get things done efficiently in a rare disease is to bring all the parties together, the drug developers, the patients, the clinical expert community, the basic science expert community, work together, have standardization, have united goals, and you will make progress in this disease, or this set of diseases. Thank you very much.
Thank you very, very much, Dr. Woodcock. I must say, that was inspirational. I hope you have the same impact on your staff and the agency that you've had in the audience today. My name is Ray Comenzo. I have an hour of work to do here with you. The work will be organized as follows. We're going to hear patients' voices to start. And as Maury noted, the voices we heard this morning were very moving, and they will move us forward. Then we'll have a keypad interlude, and then we'll hear hard data on quality of life in AL amyloidosis, and then we'll have a half an hour to chat. I will be asking people to comment. There'll be microphones available. I ask you to keep your comments to about a minute, minute and a half, so that everyone who wants to say something has the opportunity to do so. So without further ado, I'd like Karen Harris, please, come up and tell us your story. You're taking the podium, and then you're sitting at the panel.
All right. Oh, thank you, Isabel. You take me out of order, and I get confused. I'm very anal. Good morning, everyone. First, I want to thank God that I'm here today. I am... I'm grateful for this opportunity, and I want to thank ARC and the FDA for this amazing opportunity to be here today. My name is Karen Harris. I'm 55 years old, and I live in Roseville, California. I was diagnosed with AL amyloidosis in July of 2014. My free light chains when I was diagnosed was 899. They're now at 155. I have amyloidosis in my heart, my kidneys, and my bone marrow. I got the trifecta. I've had 3 different chemo regimens, and I'm now on a self-imposed 3-month chemo vacation. I needed a physical and emotional break from the side effects and issues of the chemotherapy. Right now, I almost feel like my old self. Even my family and friends said, welcome back. I actually feel like I'm alive again. But when I return from this trip, I have to start chemotherapy back again, which is a very difficult thing to do. But if I want to be here for the next meeting, that's my course. In the years since my diagnosis, I've had 122 doctor's appointments, tests, and procedures. Amyloidosis is my life now. My brain is fuzzy. I play solitaire now not as a game, but as brain training to try to keep my brain functioning and understanding and processing, which has made it impossible for me to return to my work in accounting. I have severe fatigue, shortness of breath, which I'll keep puffing through this talk. I have terrible muscle wasting and weakness, and weight loss. I put these pants on today. I bought a week ago and having a little trouble keeping them up. I have neuropathy in my lower legs, my feet, and in my hands. I was an athlete before I was diagnosed with amyloidosis. I used to do some form of physical activity every day. Golf, tennis, softball, bike riding, hiking, kayaking. But now today I can't even walk for exercise. I often miss family gatherings because I'm either just too tired or I'm too sick. So I miss out on a lot of what's going on in my life. My biggest worry, as I'm ready to start back on chemotherapy again, is managing the side effects of the disease and the chemo. because oftentimes I can't tell the difference. I don't know if the chemo's making me more sick than the disease. And after this 3-month vacation, I can kind of tell. The chemotherapy's been pretty rough. I'm not eligible for a stem cell transplant because my heart is so severely damaged they don't think that I would survive. I'm not eligible for a heart transplant or a kidney transplant because of the multiple organ involvement. So my only options are chemotherapy. And I've already blown through 3 different therapies. I'm down to some of the worst ones that I have to start now because that's all I have left. I'm not eligible for the clinical trials because I have to continue the therapies that I'm on, and most of the trials require you to be off in order to be in them. And it's too soon for the clinical trials that they think would best fit for me. Compassionate use won't be available for some time. I'm the patient that needs the new treatments and needs them faster. I need them very soon. Thank you very much.
Sydney Verrill, please come up and tell us your story.
Amyloidosis. I don't know a lot about what it is, and I can't answer many of the questions people ask me about it, but my dad has it, and I get the gist that it's not exactly something that you want to have. Its effects are continuous everywhere in his life, and the people in our family's lives also. My dad obviously endures a lot of the hard physical struggle, given that he was the one who was diagnosed with it almost a year ago. He had to undergo chemo every Tuesday for months until just a couple of weeks ago. He's supposed to be done with it now, and I hope that's true. He also has to do dialysis treatments because the amyloidosis has gotten to his kidneys. There was a point where they pretty much weren't functioning at all, and they've never gone back to normal. He now has to do a treatment every day, and one session consists of most of his daytime. My mom is an awesome caregiver, though, taking up a full-time job at a hospital to gain better health care benefits to pay off the medical bills that just keep on coming. And my sisters have all been great, too. My second oldest sister does his dialysis treatments, and she trained with him to do that. So when I think of what I do for my dad and how I can help, it's not that easy. Because I'm the youngest and the most shy and the most incapable of really helping in any way. When I think of all of this, why we're all here, how my dad has amyloidosis, why just what we're doing, I think of how scared I am. I'm the one in my family that when I heard that my dad had passed out in the dialysis chair, climbed into the smallest corner I could find, huddled down, and cried. I'm the one who tries to be oblivious to everything by talking to my dad, putting off talking to my dad about what he had until a couple weeks after he was diagnosed. I pretend that I don't overhear what the bad news the doctors told my dad now after a day's visit. And I turned down invitations to go to chemo with my dad for months because I was too scared to see him sitting in that chair getting a serious treatment for a really serious condition. It's easier for me to pretend that my dad isn't sick, because in reality, I don't know if I've ever been more scared in my life than I might not have my dad here. It scares me because the situation isn't like the movies where our characters can miraculously heal and live happily ever after. It scares me because there's nothing that I can do to make him better. I have to trust that the doctors at the Cleveland Clinic know really well what they're doing to help him correctly, because I want to have my dad for a really long time, and I hope you can make that possible.
Josh Lacey, please come up.
My name is Josh Lacey. My wife Adrian and I are from Fort Worth, Texas. In 3 minutes, I don't have enough time to tell you about all the problems that I have, but I'm just going to jump right in. We have 2 children, Addison, who's 8 years old and in the 3rd grade, and Chet, who's 4. I was diagnosed with systemic AL amyloidosis in 2012 at the age of 32. At the time our kids were 5 and 1, we were looking forward to adopting a 3rd, but now that's not such a good idea. I'm a former college baseball player, and now I'm the sports information director at a small university in Fort Worth. I began to feel sick just before my 32nd birthday, and in the first month of feeling sick constantly, I lost about 20 pounds, and I thought, hey, that's great. I needed to lose about 20 pounds. But then I had trouble swallowing, and I was full almost as soon as I started eating. In another month, I had lost another 20 pounds. I went to the first adult league softball game of the spring that year and discovered that I physically could not run. I also couldn't pick up our 1-year-old son off the ground, something that Chet took full advantage of. Every time he was in trouble, he'd lay on the ground and look at me and say, what are you going to do now? We went through numerous doctors before I was diagnosed, and because of my cardiac involvement, it was determined that I was not healthy enough to withstand a stem cell transplant. So I underwent 8 cycles of Cyborg-D with the hope of getting to a stem cell transplant. I dropped about 60 pounds and then put that all back on in water weight. I was so weak that I couldn't sit up in bed. I required around-the-clock care. Someone had to lift me to a sitting position to eat. I had to be lifted out of the bed to use the bedside commode, which was a step up from someone having to change my diapers. Getting me to the shower and bathed felt like running a marathon for both me and the person trying to help me. If we didn't have such an incredible support system and great family and friends, I don't know what we would have done. We had all kinds of family and friends stay at our house for weeks at a time so that Adrian could continue to work and support us and save her vacation and sick time for the transplant. I had a great response to the treatment, and with a lot of in-home physical therapy, I was able to sit myself up and then stand up and then get to a wheelchair. And I was in a wheelchair when Addison started kindergarten. I dropped her off on her first day, but I was too weak to go inside with her. Later, I graduated onto a walker, and then eventually I was able to walk a reasonable distance. I had my transplant in May of 2013, 2.5 years ago. I was in the hospital and missed Addison's kindergarten graduation entirely. I left the hospital at 135 pounds, which is about 80 pounds under my healthy weight. My numbers have remained in the normal range for the most part, but normal is a pretty distant memory. I still tire quickly. My beautiful children will never remember the college athlete dad who was fast and strong. When Addison was little, I was Superman to her, but she doesn't remember that, and Chet never even knew me then. Chet has always known a dad that he can easily beat in a foot race. I'm told that 10 years would be a good target for my response to last. 10 years will put Addison at 16 and Chet at 12. They don't deserve to be that kid who lost their dad in high school. I know we've already heard from a couple of people who lost their parents. and Sydney, whose dad is sick now. I need to see Addison and Chet graduate. I need to see them off to college. I need to see Addison walk down the aisle. I need to see them start families of their own, and I need to be there for them every step along the way. The idea that I'm going to miss so many of those milestones is just not acceptable to me. Thank you for your time, and let me share my story.
While we're getting some keypads for Karen, for Sydney, and for Josh, I do want to emphasize that raising your voices today, Karen, Sydney, Josh, is an heroic act because you're in a room with people who understand and with people who can do something about it, including drug company representatives, drug company doctors, whose companies have drugs that aren't available yet for AL amyloid patients, drugs that will probably work. Hearing your stories is extraordinarily important, and you're to be commended for the courage and the effort, as the other patients exhibited, coming here today and telling them. Thank you. So I have keypad questions for the AL amyloid patients who are here. And please take your keypads. Dina has some keypads for those who may not have them. We have them up here on the podium now. I wonder if, yes, thank you. So these are your choices. Check all that apply. Which of the following organs are affected by your disease? Not surprisingly, heart and kidney come in 1 and 2. Second question. Check all of the symptoms that are below which have had a significant impact, significant negative impact on your daily life. Fatigue, sleep problems. Very understandable. Thank you very much. The information is extraordinarily important because it helps the FDA to understand the dimensions of the disease at this moment in time, on this day in America. It's a great pleasure for me to introduce Dr. Michelle White, Dr. Vishali Sentrawala. They will be presenting to us their survey results, their study results, which systematically tell us a lot about the ordeals that AL amyloid patients experience. Dr. White?
Hi, thank you all. Thank you so much for sharing those stories. I feel really honored to be able to be here and talk about the impact of AL amyloidosis on quality of life from more of a research perspective. You've heard these individual stories, but we have to have a way to measure this and be able to convey it to the FDA, to drug developers, and to the world collectively. And that's what we're here to talk about today. So I'm not going to go in depth into the literature or interviews we had with patients and physicians, because you've just heard really how deeply and broadly both the disease and its treatment impacts quality of life in a wide array of areas, both physically and mentally. But how can we as researchers really help quantify this and say, well, how bad is this? How bad is this compared to multiple myeloma? How bad is this compared to something else? And one way we do that is in using health-related quality of life patient-reported outcomes. You heard Dr. Woodcock talk about the importance of the patient's voice, and that's really what patient-reported outcome surveys attempt to do. They ask about how a patient feels and functions, and that's very useful in that it can help to quantify the burden of disease and compare it to general population normative data. It can also help examine changes in quality of life over time as it relates to a treatment, and also help predict other types of outcomes like job loss and work productivity and health expenditures. Quality of life can be assessed in many different ways, and one that has been used in several different studies of AL amyloidosis patients is the SF-36, which is a general health-related quality of life survey that's been used with healthy populations and many different disease populations. It measures quality of life with 8 different domain scores that are listed up there, and 2 summary measures, a physical component summary and a mental component summary score. These scores are all standardized so that 50, a score of 50, is the score for a US average adult. And a higher score is a better score. And this helps us be able to compare scores across different groups and times. You heard Dr. Merlini say, with this being such a rare condition that it's difficult to get a large number of patients in any one time, we're conducting right now an online study, so we are able to get a larger number of patients who respond, and that helps us look at subgroups a little bit better. The purpose of our study is to help examine and describe the impact of AL on quality of life in these patients, and also to help understand if the SF-36 is valid and reliable in that patient population. It's a non-interventional study, so any type of treatment someone could be on could be in the study. And right now, patients are taking the baseline survey, and they will be followed up at 1 month, 6 months, and 12 months. Again, because it's an online survey, there's wide variation in demographics and in disease characteristics. You can even see here that the range since diagnosis is from 0 to 28 years. So that allows us to look at patients in many different ways. One thing that is very common across all of the patients we've heard so far is that 70% have had to discontinue or reduce a dose for at least one treatment because of tolerability problems. So tolerability of our medications that are being used is a huge issue for these patients. When we look at treatment characteristics, we also see a wide variety in our sample. We have about 7% who are so newly diagnosed as to not have started a treatment yet, and almost 30% who have had 4 or more treatments already. And we also have a great variation in response to treatment, with even 42% of our sample who are right now in complete remission, which also helps us look at different quality of life impacts in a different way. So now that we've talked a little bit about who is in our study, let's look at some of the outcomes. This graph shows along the bottom, or x-axis, the 8 different summary measures, and for those of you in the back, I'm going to read them. Physical functioning, role functional, bodily pain, general health, vitality, social functioning, role emotional, and mental health. And then the 2 on the right are physical component summary and mental health summary. The blue bars represent the scores, the average scores, for each of these domains for the total sample. So this includes those 42% who are in complete remission and those who are newer and more severe. And you can see, compared to that average score of 50, and again, remember that the higher the score, the better the health, there's deficits in all areas. There's not just one area or two areas. All areas have deficits. Now I'm going to overlay the green bars, which are patients in our sample who were diagnosed less than 12 months ago. And this is important because you can see not only do they also have huge impairments in all these areas, but that the impairments are much greater than those in the full sample. So it's important for us to look at different subgroups within those who have amyloidosis. I'm going to zero in now on physical impairment only, the physical component summary. And I could look at this for each one of the domains, but due to time, we're just going to focus on one today. Again, we have the score of 50, which is the US norm. And each of these groups that we're looking at have a different score. So I think it's important to note that there's not one size fits all when it comes to impact on quality of life. The different subgroups we're looking at here, those that appear to have the worst quality of life when it comes to physical impairment, are those who are diagnosed less than 12 months ago and have cardiac impairment. They have a score of about 34, which is drastically lower than the average US population score of 50. Those who were diagnosed less than 12 months ago, regardless of organ involvement, have a score of 37. And our full sample, that again included some that were in complete remission, have an average score of 41. Those who had received a stem cell transplant have an average score of 42. So again, the variation is important. But we don't have a whole lot of information yet on the impact on quality of life for AL amyloidosis. So one of the advantages of using a tool like the SF-36 is that you can look at other conditions that have known morbidities and say, well, what are those scores? What does this mean? And here we've compared it to two different conditions that we know to be physically debilitating. One is rheumatoid arthritis that has an average score of 41, and that just happens to be the same as the full amyloidosis sample. I did not pick that out before we chose these conditions. That just happened that way. And then the other is chronic lung disease, which happens to have an average score of 37, which is the same as those who were diagnosed less than 12 months ago. So again, what we're seeing here is we have there's 224 patients so far, and we're still enrolling, real-world study, confirmed our previous findings that AL patients have serious impairments in quality of life. And these impairments range across all areas that were measured. The physical impact has comparable scores to other conditions that are chronic and that we know are very physically debilitating. And the degree of impact varied greatly among different subgroups. Those with the most impairment included those who were diagnosed less than 12 months ago and those who had cardiac involvement. Those who had less impairment are those who had stem cell transplants, and obviously those were successful for those patients that are in our study. So we will be conducting further analysis as the follow-up data comes out, and now I'd like to invite my co-presenter, Dr. Sanchal Awara, to come up.
Good morning. Thank you, Michelle, for the introduction to SF-36 forms and the burden of illness in patients with AL amyloidosis. All patients who visit the Boston University Amyloidosis Center are requested to fill out the SF-36 forms at the initial visit as well as at the follow-up visits. This study, which is being presented at the American Society of Hematology meeting in December, looks at self-reported symptoms of depression, anxiety, and role limitations due to emotional problems which are derived from SF-36 forms. 1,414 patients with AL amyloidosis had SF36 forms filled out. And to our surprise, what we noted was patients' self-reported symptoms of depression in about 38%, and almost half of the patients reported symptoms of anxiety and role limitations due to emotional problems. Patients with cardiac involvement and history of smoking had higher odds of reporting symptoms of depression and anxiety. Furthermore, age greater than 65 years was the only significant predictor for role limitations due to emotional problems. Indeed, these symptoms of clinical illness, of depression and anxiety, can be significant comorbidities that require further attention as part of a multidisciplinary attack on this devastating disease. This pivotal analysis of our experience showed an improvement in quality of life of patients with AL amyloidosis treated with high-dose melphalan and autologous stem cell transplantation, reported in 2004 in the Blood Journal. The purpose of this study was to examine changes in quality of life after this aggressive treatment and to assess whether quality of life was independently associated with survival post-stem cell transplantation. 701 patients with AL amyloidosis were evaluated at Boston University from July 1994 to 2002. 544 patients had SF36 forms filled out at baseline and at follow-up visits. The following analyses were performed in this study. Baseline and follow-up SF36 scores were compared to population norms. Bivariable analyses were conducted to examine the associations between SF36 and clinical and demographic characteristics, as well as associations between SF36 and complete hematologic response. And finally, a time-to-event analysis was performed to examine the independent effect of quality of life on survival. The clinical characteristics associated with reduced physical component summary were performance status, neuropathy, liver disease, and weight loss. In contrast, the clinical characteristics associated with reduced mental component summary were neuropathy, weight loss, and performance status. There were stronger associations between clinical characteristics and physical component summary compared to mental component summary. Scores were significantly lower on all 8 SF domains that Michelle discussed earlier compared to age-matched population norms in 544 forms. The mean physical component summary was 34.5 for patients with AL amyloidosis compared to 46.8 for the age-matched population norm. Similarly, mean mental component summary was 45 for patients with AL amyloidosis compared to 51.5 for those with age-matched population norms, and these differences were statistically significant. All SF36 scores improved after treatment. The red squares are the baseline scores, and the black circles are the age-matched population norms. As shown here, the mental component summary scores reached US population norms by 1 year following stem cell transplantation, whereas physical component summary scores reached 2 years at US population norms following stem cell transplantation. The SF36 scores were also useful in modeling factors related to survival after treatment of stem cell transplant. For early post-stem cell transplant survival, better physical function and higher dose of melphalan were positive factors, whereas weight loss and heart involvement were negative factors. Of factors evaluated 1 year after stem cell transplant related to better survival, performance status, organ system improvement at 1 year following treatment, and vitality were predictive in 2 independent models. Of note, physical function and vitality are important components of health domains of SF-36 forms. Thus, SF-36 scales provide information independently that is relevant to survival and clinical outcome in AL amyloidosis post-stem cell transplantation. In conclusion, this study demonstrated that SF-36 provides relevant information for patient outcomes in AL amyloidosis. There is an urgent need for more treatment options to address the unmet need and quality of life impacts affecting patients with AL amyloidosis. SF-36 is an important quality of life tool to use as a study endpoint in clinical trials for AL amyloidosis to quantify the benefit of new treatments from the patient's point of view. Thank you for your attention.
Sorry, please sit down. Thank you, Dr. White. Thank you, Dr. Sancharawala. I think there will be helpers who will be running up and down the aisles with microphones. I see them. Hi, Ruth. One simple point is that survival curves, statistics, while they're extremely useful, do not tell the story, and that's why you're here today. And that's why the FDA is here today, too. Thank you, Dr. Goldsmith, for being here. And I'm going to ask you, if you would, to please join the panelists. It's Dr. Jonathan Goldsmith. Please. Well, it's time to chat. Where are we, Ruth? Please.
Hi.
Please introduce yourself. Tell us where you're from.
I'm Peggy Gershman. I'm actually from 2 miles up the road. Thank you guys all for coming. You could have stayed at my house. I had a stem cell transplant as my first treatment in July of 2012 at the wonderful Mayo Clinic. And since then, it's been and I didn't respond well to that, and I've had 2 other treatments. A couple weeks ago, started another treatment. I'm on my 4th. And we'll see what happens, but the quality of life surveys, all the data that I get asked, seem to focus on, they don't look enough at what happened because I got treated. I broke 3 bones in 1 year, probably because of steroid use. I can't sleep, probably because of steroid use, which makes me, I don't know whether when you're trying to figure out why things are happening, when you measure fatigue, or sleeplessness, are you just accounting for it with the drug or the disease, as opposed to, I mean, all of us who have taken treatment have taken steroids, and they wreck your life, and kept me out of work. And so and as a result of the stem cell transplant, my immune system is permanently crappy. So I get sick easily. So these things, and actually at one point, my Mayo doctor said, you know, most of the drugs you're taking are because you got treated, not because of anything else. I can't get vaccines for certain things. So all these things feel like a sideline in when you're measuring things.
Okay.
But I don't know how you distinguish between.
Yeah, it's a good question, Michelle.
Yeah.
So the question is, how do you do the correlations?
Yeah, there's several different ways to gather information from patients, and 2 of the studies I wasn't able to go into detail on today had to do with more qualitative interviews that attempted to elicit concepts of what is important, both related to the disease and related to the treatment. And we have done some of those studies, and we're presenting those results elsewhere. So I think that's one thing, is that survey data is one type of information, and in-depth interviews with patients is another. And again, there are lots of surveys that it's important to sort of measure things as they are important for general health-related quality of life, which is what I spoke about today, and then also more what's related to your disease-specific and treatment-specific quality of life. So what's measured should be a combination of multiple types of information. And I know that's pretty broad, but hopefully that helps a little bit.
I'd like to ask Karen to comment on what you just heard, because you had a similar experience.
Well, yeah, as a patient, I had
when I was in the chemotherapy and I was so sick, my personal thought was it was the disease and I was dying. That's how I felt. And when I told the doctor I didn't want to take the chemo anymore, I said, I'm quitting, this is it. I really felt like it was my end-of-life decision. And then after a month of being off of it, and I started feeling my strength return, I started feeling my zest for life return, and I started realizing now I could walk from the bedroom to the living room and not experience, extreme fatigue and shortness of breath. And even now, I'm laughing again. It's amazing how many people stop me and say, you look good. For people to single you out and say that, normally they say it's a nice top or, your hair looks good. But, people really single me out and go, you look good. And it's like, God, how bad did I look, And I'm glad I didn't know.
And that is why it's important today we only were able to present baseline findings, but to be able to look over time and to do some correlations and look at some
Thank you,
statistical
Michelle.
findings.
I'd like to ask Dr.
Important.
Goldsmith, you're hearing things about what we call in the trade adverse events. And please speak to the challenge of distinguishing adverse events from the consequences of the disease.
Sure. Well, I'm not a world authority on this, but there clearly are complications of every kind of therapy that's given, and it's an important part of drug development, the way that we think about things, to try and monitor that. But we also have to understand what are some of these complications as part of the natural history of the disease. So it's very important as you develop cohorts that you wish to study is to understand the natural history of the disease and what some of the complications are of the disease, so that if you do have an interventional trial, then you'll be able to tell the difference from what is it that the disease is causing versus what might be attributable to the new therapy. And that's very key in terms of drug development and for our understanding of the benefit-risk ratio of therapies for amyloidosis.
Thank you, Dr. Goldsmith. Now we're going to hear from the Heartland. Kathy from Ohio.
Yeah, I'm Kathy Kuntz. I'm from Columbus, Ohio. I was diagnosed with AL, amyloidosis, in February of 2013. I went through one round of chemo. I had a successful stem cell transplant at Ohio State University. And by all measures, I'm doing exceptionally well because I was one of the fortunate ones who did not have cardiac involvement, although I have significant liver involvement and a liver that's about 4 times the size of normal, kidney and GI involvement, and shared similar experiences with the weight loss and the fatigue and the GI problems that many of the panelists have shared. I also have 2 daughters. They're both starting to enter adulthood, and like Josh, I want to be there and help them grow into that. My youngest daughter was 15 when I was diagnosed, and I was always the strong one. My daughters looked up to me as the strong one, and even the younger one, when I was trying to help her understand the gravity of the disease, I said, you do understand people die from this. And she looked at me and she said, well, people do, but you won't. And so I am physically doing well. 15 months after my transplant, I rode 180 miles in a cancer fundraising cycling event, and I've done it every year since then. But what's not obvious to people is everybody thinks I'm back to normal, and I'm not. And I struggle with a lot of the psychological issues that you were talking about with depression and anxiety. I'm an executive. I lead a team. And it's been difficult to deal with some of the challenges of that. They'll come to me with problem situations that I know in the past I've been able to frame up and bring the team together and make progress. And now I can't. And I describe it as like sitting in the car and stepping on the gas, and it just doesn't go. I don't know if it's from the disease or from the treatment. I don't know if it's just aging, but I don't think it is. I was doing Lumosity before I got sick just because I was turning 50 and thought it would be good. And my scores after the disease are about 30% lower in some of the major categories. And so, I look physically by any measure, all my biomarkers are normal, but I'm not. And it's that impact that I think this research on quality of life and using the quality of life measures is equally important, because should be at the peak of my career and really financially contributing to my husband and my ability to have a solid retirement. But since I've been back to work, I was moved into a role that was lesser because there were concerns about the physical stress of my prior role that was very stressful and required a lot from me. And it's been a challenge, and it's it hasn't had an economic impact yet, but I'm just waiting for that day. Thankfully, I work for a very compassionate employer, but I know it happens to many, and so I'm an example of that, the psychological impact.
Thank you, Kathy. Thank you for raising your voice. Please. Yes, sir. Tell us where you're from and who you are.
Hi, I'm Mark Brum. I am from Ocala, Florida, right outside of Gainesville. And I was diagnosed with AL amyloidosis back in February of 2012. Went through about 4 months of chemo and underwent stem cell transplant. And as you, I had a very good response to it. I was discontinued from any other treatment after that, and I regained strength and so forth. But as you, I worked for the University of Florida, where they treated me, and yes, UF. And I work in computer systems analysis, which ends up meaning that I'm supposed to wake up nights when things don't work well and the brain doesn't work well. I was in a role as being a team lead, which I had to put aside. The mental impacts of it, where I cannot measure it, I know that I am not where I was before all of my treatment. Then I ended up last year having to undergo an aortic heart valve replacement. I couldn't undergo a mechanical valve because of Coumadin and the impact that would have hematologically on my condition. So I end up going with something that is going to have to be replaced in a few years. The mental stress and all the issues that are involved, that every time I have some other issue that I have to have treated, all of a sudden I am swelling up with fluid retention that within a week of treatment, I'm gaining 12, 15 pounds just in water weight. People look at me and say, Mark, you look like you're doing great. And really I am. But I look in the mirror and I say, I look great for a 70-year-old man. I'm 61.
Thank you, Mark. Thank you. Okay, if I ask you a question, Sydney? So when I was 15, I looked up and saw adults all around me and thought, they're running the world, they've got a lot of power, I've got to sneak out and get a cigarette and that sort of thing so they don't see me. Now you see that the world is really divided into the healthy and the sick, and it's driven home in your family. Has it made you grow up faster?
I guess maybe in some ways, but I don't really think so.
So you don't think it's made you grow up faster?
No.
Okay. Has it made you understand the world a little better?
Yeah. I think so.
I think it has, and your courage coming here today to share your story, it really touches all of us.
Yeah.
Hi, good morning. My name is Jose. I'm a caregiver for my wife, Christina. She was diagnosed with a very rare case of amyloidosis last November. She has been having issues for years, but she was, because her lungs were involved, doctors thought she had another condition called bronchiolitis obliterans. So she was treated for it for years, but there was no improvement. So last year she had a collapsed lung, and during intervention they diagnosed her with this disease. Her case is quite rare because it affects mostly the lungs, but also skin, and has a little bit of cardiac involvement. She had a chemo, 2 rounds for 2 months, didn't work, Cyberdy, so they decided to move up the stem cell transplant. She was able to have it. And right now she's in remission. Her hair is back because she was really concerned about the hair and so on. And she's doing quite well, actually, especially after what I heard today. And yeah, physically she looks much better, but for her, physically it's a struggle, anything, just to pick up something from the floor or just to walk. She used to be also a very avid athlete. She used to run marathons. She did 12 plus hundreds of shorter races. So for her, it's really a struggle just not to be able to do a lot of things she was taking for granted. She was treated in, we are actually originally from Spain. We live in New York, in Brooklyn, and we are lucky to, I must say, to live in New York because there's many places where she's been treated right now in Columbia Presbyterian with Dr. Susan Lynch, and it was fabulous, the treatment she's receiving there, so she's been pretty well. But, apart from the physical connotations, also obviously mentally she's not right there yet, also because considering this disease, which is so rare, her case is even so rare, the fact that also she has latent multiple myeloma, which also forgot to mention, so it makes kind of a trifecta as well, I guess. Right now she's in a better place. She could be here, but it was a struggle for her to come here too, and also she's very emotional, so she wouldn't talk at all here. But anyway, so right now, the most difficult thing for her is the fact that we are both from Spain and our families are over there. She cannot travel by plane because one of her lungs is really wasted and the other one is not doing well either. So she cannot take a plane. So the only chance we have probably will be to take a cruise.
Thank you.
Anyway.
Thank you.
Okay, very well.
Thank you. Yep. There are people with their hands up now. We have about another 8-9 minutes. And I do think that if you have a question, particularly for the panel, that would be great. You don't have to share your personal information with the group. I think we all have a sense of where folks have been. But please, Lois.
Good morning. I'm Lois Singer. My husband, Richard Singer, is the patient. I am the caregiver. And in July of 2005, Dr. Comenzo did a stem cell transplant. My husband had kidney involvement, and thank God he never really lost use of his kidneys. But over the years, and it's been 10 years, and he is not on any meds, but the psychological and emotional part of it never goes away. And every 3 to 4 months, he goes to do his 24-hour urine catch and his blood work. And for 2 weeks before and 10 days after, I'd rather not be in the same house with him. It is difficult, and we always talk about it. And I said, you're fine. And we just saw Dr. Comenzo in July, and we just went recently for tests at Johns Hopkins. But he feels like a time bomb. He said, I never know from one test to the next. You talk about numbers. I think all of you live with the numbers, and your caregivers live with those numbers as well. I don't know when it's going to come back. I don't know when the numbers are going to change. And right now, there are meds out there that could help him, and probably a lot of people in the room. But we need the FDA to approve these drugs for amyloidosis. And I applaud you for today.
Thank you, Lois. Thank you.
My name is Rick, and I'm from Philadelphia, AL amyloidosis. I'm not going to get into my nightmare of the past 2 or 3 years, but I wanted to thank the FDA very, very much for being here. And especially the doctors. My doctors are from Boston Medical, and I think this is the first time you may have all been in the room at one time. And I want to just thank you very, very much for the care that we get as amyloidosis patients very much. I just want to thank you all from the bottom of my heart for everything that you do for us as patients. I got my diagnosis in 2013. I know a patient of yours who is 20 years or 25 years out from a stem cell transplant, which absolutely gives...
I was a mere child.
You must have been very, very young. Because I got the diagnosis and I started to Google it and do all those things that we shouldn't do as patients. And I said, well, it's all over. It's such a rare disease. How can anyone be paying any attention at all to this disease? I'm a small business owner, and a lot of it's about money and it's about market. So as patients, I'm just curious, as this ends, I'm going to be doing some fundraising work and doing all I can to try to raise money, probably for Boston, because I think where I go, Penn Medicine, I think they've got plenty of money. So we're going to do from my business some money to raise. But what else can we do as patients and as a group to help this process along?
That's a great question, Rick. I'm going to ask Dr. Sanchwarala to tell us in about 30 seconds what patients can do.
I know. Raise money for Boston University. I know. No, I think
well, you have a memorial fund.
Yes.
For the late David Selden, who would be here if you were alive.
I know.
A great man.
Absolutely. I know. And that was the tribute to him by presenting the quality of life data, because it was his vision, who really, got the data together in 2004 to, put it in Blood Journal, so definitely.
Okay, we have time, I think, for 2 more quick comments, and then I have to turn the microphone over to Dr. Gertz, because if I don't, he'll rip it out of my hand.
I'm Marie Tompkins from Washington State. I have cardiac amyloidosis and also in my tongue and salivary glands. Treated at the Mayo in 2008, complete response since then. I thank patients for sharing your stories, and I'm just glad that I could be here. And one of the things I wanted to share is that I was recently diagnosed with post-traumatic stress syndrome because of all I went through getting diagnosed and so forth, and I'm currently in treatment for that. And the other thing is I have sleep apnea because of the tongue and salivary gland involvement, and my fear is I keep hearing that sleep apnea can cause dementia down the road, and I don't want another disease. So I would really like to get a drug that can get rid of the deposits in my salivary glands and tongue. Thank you.
Thank you, Marie.
I've already spoken, but what I would implore the researchers to think about is I've never met such tough cookies as I've met with the amyloidosis patients. My story is one of so many normals. I never missed a day of work with my stem cell transplant. I was a teacher, did it during the summer, and that was it. But with the quality of life measures, to really think about what our new normal is and what we think of as okay. Because we're okay and we're psyched about that, and that's a high score, but that might be somebody else's very low score. So I just would, when we look at quality of life, thinking about normalizing our data a little bit, because people are amazing at what they're okay with.
Maury, do we have time for one more comment? Yes. So where are we? Back there? There were people with their hands up? Ah, great.
Hi, my name is Ruth Mrozinski. I'm from Chicago.
I was diagnosed with AL amyloidosis in 2013 of July. I went through 3 doctors before I got a diagnosis, and it was my cardiologist that sent me for a cardiac MRI. And then I was followed at Advocate Lutheran General Hospital in Park Ridge, Illinois. I have amyloidosis to my heart, my kidneys, my liver, my skin, GI, nerves, everything. I was hospitalized for 3 months. I was on dialysis for about a month. I was in ICU for a month due to hypotension. I developed such severe atrophy that I had to go to acute rehab for 7 weeks and then subacute rehab for another 7 weeks before I came home 2 days before Christmas. This is my husband, Ed, who was my caregiver when I came home. And I had some weakness in my left leg, and he was able to build me some portable boxes that we used on the stairs to get up to the bedroom. And not being able to really shower yourself or anything. I'm doing much better now. Still have to use a cane. I've come a long way for the last 2.5 years, and I just want to thank the FDA for being here, and we need these drugs fast.
Ruth, thank you. Thank you. And thank the panelists.
We're going to continue talking about AL amyloidosis. We're going to focus during this next section on therapy and clinical trial availability. As a provider in the day-to-day busy practice, sometimes with the tempo, it's sometimes a little bit easy to lose sight of why I'm there. And I am actually quite grateful for the impassioned stories that I've heard, because it helps refocus and remind me why I do what I do. So thank you for that. I'm also quite sympathetic for those even who are doing exceedingly well, because for an ostensibly incurable disease, every office visit runs the risk of waiting for that other shoe to drop. It is devastating. I also have patients who are physically ill and have nausea in anticipation of their return to find out what lies ahead. Our first speaker is Angela Dispenzieri. Dr. Dispenzieri chairs the Hematology Research Program at Mayo in Rochester, and she's also the leader of the Amyloid Interest Group in Rochester. She's a professor of medicine and laboratory medicine. She was instrumental in first recognizing NT-proBNP as a critical biomarker in amyloidosis, did a lot of the development testing for the free light chain assay. She's done a lot with regard to the therapy of amyloidosis, including recognizing some of the unique side effects of some of the agents. Those of you who have seen her know that she's a very caring and giving physician, and just as importantly, she is my bridge partner. She's better at NT-proBNP. So, Dr. Dispenzieri.
I'm better at amyloid than bridge. Anyway, so I have the easy task of talking about therapies and clinical trials in amyloidosis in 5 minutes. So here we go, a very sort of high-level view. The current state right now in amyloid is there are no FDA-approved drugs for AL amyloidosis. We are currently using a lot of myeloma therapies in patients with amyloid, but finding that there's a lot more toxicity in amyloid patients than we would otherwise see in myeloma patients. The clinical trials that are done typically are excluding those patients who are the sickest and in the most need. This is a survival curve over a course of about 40, 50 years, patients, nearly 5,000 people with AL seen at the Mayo Clinic. What you can see is that there definitely has been some progress over time. So this is per 10 years, so this is back in the 70s versus here in the later 2000s. So there has been some progress, but obviously it's not good enough. The other thing that you can see is that patients, we are losing a lot of patients in the first 6 to 12 months. And you've heard this before, but this has to do with the lack of early diagnosis, delayed diagnosis, cardiac involvement. So again, the treatment of amyloidosis to this point has been all directed at the plasma cell. We've heard that the plasma cell is what's making the amyloid protein or precursor proteins, which are potentially toxic, both directly and also by forming amyloid, causing tissue deposition and organ dysfunction and death. So what we do is we use drugs like alkylators, steroids, high-dose chemotherapy with stem cell transplant, more recently the immune modulator drugs, and the proteasome inhibitors. The idea here is if you get rid of the plasma cells, we don't have the toxic proteins to form amyloid, and then there can be not only the lack of progression, but also the opportunity for regeneration and healing. As we are moving in time, however, there are other approaches. So there's some preliminary data that perhaps doxycycline and also the extract of green tea, EGCG, may be inhibiting proteotoxicity. And really very exciting is this strategy of actually going after the amyloid itself with monoclonal antibodies, both monoclonal antibodies directed at the sort of more light chain epitopes, but also at part of the SAP, which is integral in the amyloid, so using SAP depletion as a strategy. If you look at clinicaltrials.gov, you'll see that there are a total of about 14 interventional trials. There are 8 that are directed at the clone or the plasma cell. And so the first one is bortezomib melphalan-dex versus melphalan-dex, which is actually only being conducted in Europe at this point. And then you can see there's bortezomib with high-dose melphalan as part of transplant versus just the high-dose melphalan, ixazomib index versus standard of care, which is one of 3 different regimens. So those are randomized phase 3 trials. You can see that other drugs are in phase 2 or phase 1-2 trials as well. And then we also have 6 trials that are directed at the amyloid specifically. And you can see that we have the NEO-D plus standard of care versus standard of care alone, and that standard of care is Velcade, Cytoxan, and dexamethasone. Some phase 2 work repurposing doxycycline, and then also the EGCG, and then more work with monoclonal proteins. In terms of off-study, the approach is complex, but basically, as you all have heard and know through your own experiences, often patients are divided into going down the path towards transplant, stem cell transplant versus not, and we use biomarkers to help us decide that. A lot of it does revolve around the NT-proBNP, cardiac function. Regardless whether one goes down the left panel, which is the transplant panel, or down the right side, which is not the transplant panel, which would include an alkylator and steroid, and often a proteasome inhibitor like bortezomib. The decisions as one has done the therapy and one is going along the therapy is all based on biomarkers. We follow the free light chain. We say, have we done well enough with that? If we haven't gotten to a very good partial response, we'll say, what are the cardiac biomarkers doing as well? Is there an urgency to change or not? And so all that we do in this sort of complicated decision-making is dependent on biomarkers. You can also see for relapse disease, we're borrowing from the myeloma treatments because that's what we have. And most of this work is really all phase 2 and retrospective data rather than good phase 3 trials in the relapse setting. And so in summary, the recommendations I would put out, there is an amyloid community. Physicians are here, many that are the amyloid community. We have done consensus documents, and we need to go further, consensus documents and agreements between FDA and the amyloid community with input from patients. And I thank you for your time.
We're now going to hear from 3 additional patients on their journey and some of the saga associated with management. So I'd like to invite to the podium Magit Kegel.
Hello, my name is Margit Kegel. I'm 64 years old. 16 months ago, and 6 months after I had an embolic stroke, I was diagnosed with primary amyloidosis. I have heart and kidney damage from the disease, and I'm told that the atrial flutter in my heart is likely the cause of my stroke. My stroke was to the part of the brain that affects speech. So if I speak hesitantly to you, and if I make mistakes like calling myself 24 instead of 64, please consider it the responsibility of my stroke. My physicians in Oregon were unfamiliar with treating amyloidosis. And so the cardiologist who saw the sparkling on my heart said, "You need somebody smarter than me." So my husband and I went to the Mayo Clinic in Rochester for consultation. I had treatment there with what is familiarly known as CBORD. This combination that included very good medicine and resulted in good treatment for me. I had a partial response, and in 4 months, there was some organ improvement, but it came at a high cost. I got severe neuropathy with tremendous amount of pain, and I have weakness from my neck to my feet, along with pain and paresthesia. By profession, I am a physical therapist. I have worked with children who have movement disorders for 40 years, but I can no longer work. Because of the immunosuppression that I have, as well as the poor balance and weakness, I can't do that work with children. So no work means no insurance. Something that we now have to buy at a very dear price. I cashed in some retirement accounts to pay for the treatment, but life doesn't look very familiar after amyloidosis and its neuropathy. We sold our home in Oregon, and we now live in an apartment in Chicago near one of our daughters. It's a fearful disease, and it makes you want to be by your people. My favorite leisure activities before I got this treatment involved hiking, cross-country skiing, snowshoeing. I celebrated my 60th birthday by backpacking into and out of the Grand Canyon and by hiking to the top of Long's Peak in Colorado. Neuropathy and heart disease will prohibit these activities, and my young granddaughters easily outrun me. By inclination, I am independent and an early riser, and I'm a helper of others. Now I hold my husband's hand when faced with even small irregularities like the cobbles and grates on the sidewalks of Washington, D.C. I sleep late now because of the medicine I take to manage my foot pain. I drive only short distances by myself because my hands go to sleep. Now, I qualified for a stem cell transplant, and in March of this year, I had it. It's no picnic, but I had a complete response from it, and my husband and daughters and the caring staff at Mayo Clinic helped me get by it. 2 weeks after I finished it, I spent a week in ICU in septic shock. I am now feeling much more robust, but each step I take reminds me of this disease because of the pain of neuropathy. I sincerely hope that by the time I need treatment again, options will be available to me that do not require me to choose between organ failure and progression of this neuropathy. Thank you.
Thank you. Please join us. Ms. Carolyn Wagoner, thank you.
Three years ago, I had a dream. My husband and I were planning a vacation cruise around the world on Holland America. And then suddenly, life was interrupted. My name is Dr. Carolyn Wagoner. I am 58 years old, and I'm a 3-year survivor of AL amyloidosis. I am currently a participant in the NEO-D1 clinical trial under Dr. Raymond Comenzo at Tufts Medical Center in Boston, Massachusetts. My initial symptoms that prompted me to seek medical treatment were elevated cholesterol, fatigue, and swollen feet. In February of 2012, as a captain in the Navy Reserves, I went in for my routine annual physical, and I was flagged with a cholesterol of 264. I couldn't believe it. I couldn't believe that was my cholesterol, so I insisted they retake it again. So a month later, I redid it, and it was the same result. In April, I was surprised to note that my feet began to swell, and I couldn't get my shoes on. This had never happened before. Gradually, I noticed it was becoming difficult to jog and exercise. My face would become beet red, and I would be completely out of breath, which was very uncharacteristic for me because I was a jogger. This began a series of medical evaluations, and in November of 2012, the nephrologist told me that I had incurable nephrotic syndrome. And 1 week later, after a kidney biopsy, she dropped the bomb. I had kidney amyloidosis, and it was very serious. Upon this horrible discovery, I went on the internet, and I learned that without immediate treatment, I would be dead in 6 to 16 months. I am so fortunate that my mother's research led me to Dr. Raymond Comenzo in Boston, Massachusetts. He immediately took action, which involved a peripheral blood stem cell transplant in February of 2013, followed by 6 months of Velcade and dexamethasone chemotherapy from April to November 2013, also at Tufts Medical Center. After the transplant and during the chemotherapy, some of the side effects I experienced are what I've heard today in the audience. I had severe lower leg pain in my bones, hair loss, extreme fatigue, dizziness and weakness, lack of concentration, poor appetite, and peripheral neuropathy. Additionally, GI problems caused worrisome bouts of constipation and uncontrollable diarrhea. In April of 2014, concerned that my proteinuria was still ongoing, Dr. Comenzo offered the opportunity to participate in a clinical trial for a new form of treatment called NeoD1, which I learned was a drug that might reverse my kidney damage. A few weeks later, I was accepted into the trial and enthusiastically began this new form of treatment. I have traveled monthly to Boston over 1 year now to receive what I consider life-saving treatment for AL amyloidosis. My proteinuria has decreased by more than half. I am extremely grateful to Prothena for this new drug. I have more energy to get through my day now with no noticeable side effects. I look forward to the treatments. Because of NeoD1, which is considered biotherapy, I feel there is hope for a cure for AL amyloidosis during my lifetime. What is it like living with amyloidosis? For the first year, I would sometimes wake up in the mornings and feel relieved that this was just a horrible nightmare, and I didn't really have a life-threatening, rapidly aggressive, and fatal disease for which there is no cure. Then I would get up feeling lightheaded, look down at my swollen feet, and reality would set in. Now, in most of my dreams, I have amyloidosis, and I am shackled by the restrictions imposed by a disease that leaves me fatigued and unable to do so many things that I enjoy. I was a Navy dentist forced to retire due to amyloidosis. I love ballroom dancing, exercising at the gym, and traveling. I can no longer do those activities. That dream of a world cruise has been replaced by a will to survive. Thank you very much.
Thank you, Dr. Wagner. Please join us. And for our third, Ms. Jane Pike will be talking about her caregiving experience.
I was pretty sure I was going to be the one that tripped going up the stairs, so I'm really glad I didn't. My name is Jane Pike, and my husband George has cardiac AL amyloidosis. Our journey with amyloidosis began when George was diagnosed in November of 2005 and given 6 months to live. This was not part of our life plan. Through prayer, modern medicine, and a wonderful support team, George underwent extensive treatment and clinical trials and is still here today. So I want to tell you a little bit about George. He obsesses over every home project. The tiniest detail has to be spec'd and drawn and planned before a hammer hits the nail. But when it came to amyloid, his approach to keeping positive was to mentally distance himself. He didn't want to know the potential risks or the side effects. He's actually having a hard time staying in the room. If you told him that an upset stomach during stem cell replacement might occur, it would turn into an ulcer. So George abdicated his health choices to me, a major responsibility, a burden, and an honor. Some wives say he couldn't live without me, but in my case, it's actually true. George was diagnosed at the Boston Medical Center by the incredible Dr. David Selden. George's medical team, led by Dr. Selden and Dr. Sanchawala, have taken us on a journey, starting with a high-dose melphalan and auto stem cell transplant in January of 2006. George received a partial response, and we watched anxiously over the next year as his free light chains began to increase. George participated in his first clinical trial for open label phase 1-2 study of Velcade injection in September of 2007, which was prematurely stopped due to neuropathy. Again, we watched his free light chains continue to increase over time. George began his second clinical trial of phase 2 Revlimid with dexamethasone from May of 2009 until May of 2011. I have to admit, I initially liked the side effects of George on steroids. He's always extremely frugal, but all of a sudden he wanted to spend money. However, the negative side effects, as we've all heard today, of steroids on George was to result in a heart attack in August of 2009. And we continued the trial only with Revlimid. And George received a very strong response to Revlimid. George has quarterly checkups at the Boston Medical Center, and we are blessed to have such an amazing team. But amyloid is a tricky disorder. Within 2 years, George's light chains were again on the rise. In October of 2014, George began a phase 1-2 trial of pomalidomide with dexamethasone, designed specifically for patients with AL amyloidosis who had been previously treated. I was nervous about the addition of Dex, although I did want a new bedroom set. But my worries have now become joy. Just this weekend, from Dr. Sanchawala, we were advised that George was in complete remission. Another miracle for my husband and for my family and for all patients with amyloidosis. I have to admit that at the beginning of this journey, I would have said that Kappa and Lambda were fraternity houses. But after a decade of being a caregiver to someone who didn't even want to admit he was sick, didn't want to admit any illness or weakness at all, I have to say this is my legacy, my gift to my husband, along with a lot of help from Boston Medical. Our gratitude toward BMC cannot be expressed in words. Our treatment team, including the wonderful Anthony Shelton, has continued to push us, great clap for him, has continued to push us in the direction of better health. But how can a decade pass without an improved treatment protocol for amyloidosis? My husband was diagnosed when our son Tom was only 11 years old, a student in the 5th grade. George has lived to watch Tom go to his senior prom, his high school graduation, and enter his senior year of college. Please help us in this journey. Please help us to find an approved treatment plan. Thank you.
Thank you very much. Wonderfully inspiring. Are there no keypad questions that we'll be doing, Isabel, during this section? All right, well then I'll need to access those, and again I want to thank you all for those really inspiring comments, and we'll do the keypad questions and we'll move to discussion, but I don't think I control that. So get your keypads ready, because this is very important information that we want to acquire with regard to clinical management and trial participation. So the first question asks the types of treatments that you've undergone: stem cell transplant, chemotherapy, complementary, alternative, and others. So please vote. Next time we meet, we'll put on that little Jeopardy jingle there to help time that through. Results, please. So this group actually is a little disproportionate from what our experience has been. As we review our own information, we find that no more than 20% of patients seen, at least in Mayo Rochester, are currently eligible for stem cell transplant, maybe up to 25 after induction therapy. Thank you for that valuable information. The next question, please. Regarding problems tolerating therapy, discontinued at least one medication or treatment. I've reduced the dosage for at least one medication or treatment. I've had problems tolerating at least one medication or treatment, or I've had no problem. As we focus on toxicity, please vote. Oh, I think it would be at any time during therapy. We're talking about toxicity of therapy, whether it's before or during a maintenance phase. So please vote. Yeah. Although I've had a number of partners tell me that they very much enjoyed having their spouses do odd jobs at 4 a.m. around the house. So, very significant issues with regard to toxicities that revolve around current therapies. We'll go on to the next question. We have that recorded. This is a ranking, so you get actually to vote for more than one. You get to vote for two regarding your decision about therapy. First is whether the treatment is expected to relieve symptoms and improve quality of life. The risk of side effects such as kidney damage or cardiac issues. Third, whether the treatment could prolong your life by slowing or halting disease, which doesn't refer to quality. 4, the toxicity of treatment, nausea, appetite loss. And finally, how the treatment is administered, how long the treatment takes, whether it requires hospitalization, in other words, the logistics of the therapy itself. So please vote. The timer. Thank you. While we're voting, Dr. Goldsmith, can I have you join us again at the panel, because we're going to try and focus this on questions for our expert panel as well. And so some of the drivers with regard to the selection of therapy where survival appears to be the #1 issue. So we're going to now move on again back to the audience. There are a couple things we'd like to focus on during this session. Your stories are important, but also if you have specific questions for our expert panel, both therapy for Dr. Dispenzieri, the patient experience, FDA regulatory issues that Dr. Goldsmith can handle, we can talk about the treatment, the toxicity, the availability of trials. So I think we'll look for our first participant.
Hi, it's Kathy Kuntz again. What are the barriers to utilizing patient-reported outcomes as endpoints in clinical trials?
Dr. Goldsmith?
We kind of think of these in the broader scheme of clinical outcome assessments. And we've actually, in the Office of New Drugs at Attr, we've actually developed a whole cohort of people who are interested in this area and are trying to help sponsors develop clinical outcome assessments that would be useful in terms of evaluating the effects of candidate drugs. So the sponsors would be well advised to touch base with the clinical outcome assessment people and to try and learn more about developing that technique.
Hi, my name is Felicia, and I'm from Los Angeles. I had a stem cells transplant, BU, Dr. St. Juala, back in 2010. I was diagnosed in like August and transplanted on Christmas Eve. Got a complete response, progressed after about a year into my kidneys. I had AL with cardiac origin to begin with. I progressed to my kidneys after about a year. I've done 3 different types of treatment since then. From Velcade to Revlimid. I've been on Revlimid maintenance for about 3 years now. I'm that patient that has, quote unquote, excellent insurance. I'm also a nurse by profession. People say I look very good. I have the disease. I was diagnosed.
You do look good.
So they say. But what happened for me is I come from, my insurance company is the largest HMO in the world. And they don't approve us to go for our yearly evaluations. And so I've had to become my own advocate. I've had to learn. I've had to literally learn endless, countless nights going to the amyloidosis support groups in my state that I live in. And because other than that, I wouldn't know what's out there as far as treatment is concerned. Yes, they did approve for me to have a stem cell transplant. Yes, they did. They've approved for any medication that I've brought back to them as a the the last time I saw Dr. Burke, he said, "Ms. Briscoe, I'm afraid that I probably won't see you again." Well, Dr. Burke, I'll see you again. But only because I was denied the opportunity to go back for those evaluations. And the only way that you can find out about what's in the world of amyloidosis is if some things are brought forth. So I just wanted to bring that forth, that I am that patient that has been denied treatment, but I do still survive. My numbers are still good.
Thank you for the insight. The focus of the session, some of the information that we're trying to acquire for our knowledge base are, for those of you who are participating in clinical trials, what drives your decision? How do you decide whether you wish to be or not be in a clinical trial? What do you look for in ideal treatment? What has been the toxicity, the side effects from your treatment? How much medication are you taking just to manage the side effects of your treatment? And
hi, my name is Kathy Rowan. I'm a communication professor at George Mason University, and like Felicia, Dr. Sancharawala is my doctor. In 2011, I was diagnosed with AL amyloidosis. I went up to Boston University with my husband, and Boston confirmed the diagnosis and gave me the option of participating in a clinical trial. For the two of us, for my husband and I think the major reason why we chose the clinical trial was that it was so clear that the clinical trial had benefits. There was no placebo condition in the clinical trial I was participating in. It was the standard treatment, methylene plus stem cell transplant plus Velcade and dexamethasone. So it seemed as though, how could I lose? At least in hindsight, it seems that way. And clearly it was the right decision. I'm coming up on 4 years of complete response. So it's painful to hear the challenges that everybody else has gone through, but it's also very important to see that they have made a lot of progress, and we need to continue the progress. Thank you.
thank you very much.
Yes, I have a question for Dr. Dispenzieri. You said that biomarkers completely drive the movement through the decision tree that you displayed. How then does the treatment toxicity question feed into the decisions on that tree?
Yeah, it actually does a lot. I mean, the biomarkers are important, and I'm sort of emphasizing that for the benefit of the FDA of how important they are as endpoints, but clearly it's the whole patient that fits into that, and we're going to reduce the dose of drug or change therapies or whatever based on the patient, the face-to-face. It's not like we're just looking at a computer screen. So it's a complex decision-making process, but these markers, these biomarkers, which Dr. Merlini, Professor Merlini showed us, can help us shorten the duration of trials to get drugs to market faster. They're important in trials, they're important in everyday practice, but clearly the whole patient is the most important part.
Question for Dr. Goldsmith then. So we have agents that demonstrate benefit by whatever tool we decide to use. How does FDA integrate the safety signal, the toxicity signal in weighing a global decision beyond the agent has activity?
When they do review of an application, you have to look at the benefit risk, and you have to weigh that. And the benefit has to be shown by scientific evidence that would be assessed by expert reviewers. The safety analysis fits into what's learned about the benefit. If the benefit of a potential therapeutic is very low, then the tolerance for risk is similarly very low. If the benefit is very high, then there's more tolerance for risk. And that's the way that these kind of analyses are done at FDA. If the therapy has no risk at all, then it might get licensed with very little benefit, if you want to think about it that way. That's possible if there's data that's supportive of its benefit.
Thank you.
My name is Harold Forbes, and I'm from Boston. And I had a stem cell transplant in 2005 and had a complete response. But at 2 years, I had a biochemical recurrence. So since that time, since 2007, I've been on 6 episodes of treatment, and 5 of those 6 were clinical trials. I'm lucky to live in Boston because I have access through Dr. Sanchawala at BU to these trials. And the reason I am participating in trials is, one, it gives me a better choice of drugs available for treatment. And 2, I think it's very important to have numbers of patients in studies so that the significance of these studies can help patients in the future.
Is there anyone in the audience that might be able to comment? If it's really great, really fortunate if you live in Boston, if you live in New York, but if you live in a rural area or an area where there's not a large amyloidosis center, what ends up happening really day to day?
My name's Abby Torres. I live in Lawrence, Kansas. And those of you might know it by University of Kansas, and that's about it. But I live in the Midwest, and back in 2010, I was an avid cyclist. And I used to participate in the Senior Olympics. And what brought my problem to a head was during a competition, I couldn't finish my race. So I went to the local doctor, saw 4 different specialists over 6 months, which ranged from you have asthma, you have athlete's heart, to, they put me on a treadmill. You have the heart of a 17-year-old. So I don't know, but I always had this problem where I go up a flight of stairs and I couldn't go any further. Looking back, I realized that it was like 5 years that this had been happening. I could go on a bicycle and ride 10 miles straight, but I couldn't go up a flight of stairs. To make a long story short, they sent me to a cardiologist. The cardiologist said, you just need a stent in one of your arteries. You'll be fine. That changed, went back to the cardiologist, says, I don't know what to do. Went to KU. KU had an amyloidosis specialist, and they went ahead and found out that not only did I have amyloidosis, but I had a destroyed heart. And I'm sorry. I was lucky enough that they went ahead and put me on chemotherapy, regimen of Velcade and Dex. Dex didn't work too good. I blew up, picked up about 15 pounds. They went ahead and said, let's just do Velcade. 6-month period, I went down from what I considered a high number of 157, but I found out from my doctor, Gertz, that thousands is usually more the number, so which told me I must have had it for a long, long time. Got the numbers down. He went ahead and said, go check the heart transplant center there. They saw that word amyloidosis on their website. They guarantee a heart in 36 days, and they said, no thank you. I went up to, saw Dr. Gertz. He heard about me, looked me over, and then I saw the cardiologist. Remember the first day I went in for a test, 26 vials of blood, did a complete test and everything. After short, they went ahead and considered me for a transplant, called me back for some reason and said, can you check into the hospital? 10 days later, I got a heart after that. Did 4 months later, stem cell transplant. Stem cell transplant took. I'm currently in remission. And I just want to let you know that I've heard all these stories about people who have a hard time. I don't know why I'm here. I'm glad I am. I see these stories of people that I think should be there before me, but I feel like I'm carrying the flag for amyloidosis. For those of people who think that there's no light at the tunnel, there really is. And thank you very much.
We have 5 minutes. we're all glad you're all here, actually. Please, and specifically if there's any questions for our expert panel.
I'm Mark Brum, and actually I'm responding to what I thought your question was. Someone in not a center, a large center, Ocala, Florida, Gainesville, they're small places. Yeah, we do have the University of Florida Hospital there, but that's not a center for amyloidosis. I had to track down because I was concerned about still having kidney damage, proteinuria, and with the prospect of this thing coming back at some point in your life, you want to try to get your body in as good a condition as you can so when you have to do battle against it. So what comes into the decision and what takes place is I was looking and came in to understand NEOD1, started reading about it and looking for it. I actually emailed every place that was doing clinical studies on it, and I was able to get some attention from the Karmanos Institute in Detroit. Now that means I have to now travel 1,100 miles one way every 28 days for a treatment. I'm still working of sorts, so I have to take my time off in order to do that. If clinical trials could be done in such a way in which you could do most of it locally, I mean, really, there's no reason that someone can't, at University of Florida, can't give me an infusion, can't do the blood tests, and so forth. And some of this just seems to be so restrictive. Now, mind you, I don't mind doing that because it might help me, and Lord willing, it'll help other people. But, you know, the decisions, I think, need to really come down to making these things more available through some sort of proxy agents or something.
It's a very real issue regarding the local administration of investigational new drugs and the risks that come with it. We have time for just one or two more.
So when I was diagnosed, like most patients, I did a lot of research, kind of like 6 hours after I heard the word. I did my meta-analysis, and I was like, okay, Mayo or Boston. And I was in Columbus, Ohio, with a well-respected major medical university, with a well-respected teaching hospital, and a cancer center there that is world-class. But a cancer center is not an amyloidosis center. I had to make a choice. My daughter, it was her freshman year in high school, and the prospect of having my husband away with me for 6 weeks at Mayo when I was already very, very sick was a problem. Well, what that meant is I followed the myeloma protocols, the redheaded stepchild of myeloma, amyloidosis, and I gained 70 pounds of fluid while I was in the hospital. My abdominal girth was 45 inches. That's like a pencil width shy of 4 feet. I was immovable for about a week, and so I got so deconditioned I had to go to the rehab hospital for 10 days, and my graduation criteria was being able to climb 6 stairs and being able to walk 500 feet unassisted. And so that's what being, not going to an amyloidosis center, I feel like, cost me, and not just me, my family, and my insurance company, because that 10 days in rehab was expensive, and then I was in a wheelchair and fairly incapacitated at home after that, and it was a tough treatment decision to make, and in hindsight, maybe I should have made a different decision, but that was the one that I made, and I had to live with the consequences.
We have time for one more.
I have a question for Dr. Goldsmith. Hi. My name is Muriel, and I'm with the amyloidosis support groups, and we've been doing advocacy and support groups for more than 10 years. And a question that always comes up at our meetings, always, is there's this wonderful SAP scan done in the UK, and there's this wonderful antibody that Dr. Pepis has brought to the people in the UK, and it's in clinical trials, and we've got NeoD here and other things going on here, but boy, that SAP scan thing sounds wonderful. Why don't we have it in the US? And when I have to explain to them that the SAP scan isn't accepted by the FDA because there's human blood byproducts in it, and they get it because we've all been through the AIDS thing, SARS and all those things, and we get why, human blood byproducts aren't a big thrill in the USA. But then we hear our amyloidosis patients saying, I'd be willing to take that risk, and I'd be willing to have human blood byproducts in my body to get this antibody in me. And I'm wondering if there's some sort of exception to the rule that could be done for our amyloidosis patients so that they could get the SAP scan here in the US, and if not, why not?
I'm not actually familiar with this particular agent, so I think it would be out of turn for me to talk about it. But if you have something that's approved in country A, it would have to go through rigorous review in country B to determine if it was safe and effective. We have an independent system here. That's why the FDA is probably the most revered review system in the world, because we actually do a very thorough job and we do it independently.
The morning session is drawing to an end. Just a reminder, so the morning session was focused on AL, immunoglobulin light chain amyloidosis. The afternoon will be focusing on both wild type and mutant ATTR amyloidosis. Isabel, do you want to make some just housekeeping comments before we go to lunch?
Yeah, lunch is going to be served next door. They're box lunches, and we really have a full session this afternoon, so be timely. If you want to bring your lunches back in here, that's fine, and we will really start promptly at... Yes.
And 2008, Dr. Dispenzieri was and still is my physician, and I am just very grateful that she is. So that's all I needed to say.
Thank you. So 12:45, everybody back here, please. Thank you. Sharp.